Dear colleagues, it is my great pleasure to welcome everybody to the Science and Tech Innovations in Ophthalmology conference that will be held this afternoon. This is organized by the Polish Ministry of Education and Science, University of Warsaw, Foundation Ophthalmology 21 and company Mark 21. And also Alpha Event Company. We have sponsors for the conference. I would like to acknowledge their contribution, Tactica Pharmaceuticals, Bausch & Lomb, Beatrice, Santen, and Lumibard Medical Polska. I would like to thank them for their support. Regarding media patrons, we have the Ophthalmologist magazine from UK and the Medycyna Praktyczna portal, the largest medical platform in Poland. Regarding the program, after the opening lecture that I will present at the end, we will move to the sessions. This is the first session, as you see, use of new technologies of ophthalmic practice. That the session will be finished as every session, as a matter of fact, with a discussion. So please prepare your questions and add the questions at the chat. Well, let me also add that the conference is simultaneously translated and it is provided in both languages, in Polish and in English. So for English-speaking attendees, please use this option, and discussions might be held in Polish also. So if you hear Polish language, then just simply move to the English translation. We have the simultaneous translation provided, so it is no problem. All presentations are provided in English. Then we have the use of new technologies in ophthalmic practice. As you see, very interesting session. And again, the discussion and the break, a short break. Then we have the third session, again, about the use of new technologies in ophthalmic practice. I will not discuss each presentation. Everything is clear in the program, and then the next session about the a bit of AI, OCT, future AI imaging, and the last session with some international speakers about the ocular genetics, cornea diagnostics, AI in ophthalmology. We have speakers from France, Germany, and US, and we plan to finish the conference around 7 o'clock. So let me now move to the opening lecture that is named by Tadeusz Krwawicz. This is a very important and Polish history of ophthalmology, because Tadeusz Krwawicz was a very important, as a matter of fact, one of the giants of the 20th century ophthalmology. And we want to commemorate him, and we feel that he is probably largely forgotten. He was the inventor of cryosurgery in ophthalmology, the technique for cataract extraction that was used, or now is replaced by phacoemulsification, and this is probably the reason why he is forgotten. However, this technique, cryo extraction, was a dominant cataract extraction method for around 2 decades all over the world. He is still remembered by the gold medal that is given by International Council of Ophthalmology, and the first year it was established was 2005. So pretty finally long time, 20 years. This medal has been given. This is my great pleasure to introduce this year lecturer of the opening lecture, Professor Marcin Stopa, who is a fellow of European Board of Ophthalmology, and he's also a board member of this respected, important European organization. He is a professor of ophthalmology at the Poznań University of Medical Sciences. He completed his residency in Poznań and two vitreoretinal research fellowships in New York and in Durham in US. He is currently the head of the Department of Ophthalmology at this university in Poznań, and he is also editor-in-chief of Acta Ophthalmologica Polonica. He is also a board member of the Polish Society of Ophthalmology. His research interests include vitreoretinal surgery, trauma, macular hole, complex retinal disorders, diabetic retinopathy, subretinal gene delivery, subretinal hemorrhage, and retinopathy of prematurity. So he is one of the best experts we could have for in delivering the innovations in vitreoretinal surgery. And at the end, I would like to invite everybody to our next two meetings. Both are held in November. Presbyopia, as you see, November 8th, and the link to the registration is already given. So it's again, it's a free meeting because of our sponsorship by Polish Ministry of Education. And the program soon will be available. And case reports in ophthalmology, the meeting that is held for nearly 10 years at the end of November, as you see, with many international cases and international speakers. So again, I remind you to place your questions in the chat to be part of this conference. And thank you for your participation. Now let's listen to the opening lecture.
I would like to thank Professor Andrzej Grzybowski for giving me opportunity to hold Tadeusz Krawisz lecture. In this presentation, we will explore exciting innovations that have a potential to revolutionize the field of vitreoretinal surgery. When discussing innovations, it's essential to start at the very beginning. This is the story of Professor Robert Mahamer. He performed the first vitrectomy in 1970 using a 17-gauge system, which means his vitroscatter was 1.41 millimeters in diameter. Initially considered unsafe and ineffective, the surgery has evolved into a highly technological and predictable procedure. My talk will focus on technological advancements in vitreoretinal surgery. I will discuss sclerotomy and valve trocars, scleral buckling using a chandelier illumination system, 3D heads-up displays, head-mounted displays, and intraoperative OCT. I will also talk on future directions in vitreoretinal treatment, such as robotic vitrectomy and gene therapy. And finally, I will also discuss some of the unresolved issues in this kind of surgery. Sclerotomy techniques have undergone a remarkable transformation, significantly improving patient outcomes in eye surgery. We have progressed from 20-gauge instruments in the early 1980s to sutureless sclerotomies utilizing 25 and 27-gauge needles of today. Additionally, the introduction of valve trocars prevents fluid leakage from the eye, further enhancing surgical precision. These smaller incisions translate to shorter operating times, improved wound closure, and ultimately faster visual recovery for our patients. And this evolution underscores the ongoing commitment to refine surgical techniques, minimizing patient discomfort and accelerating their return to normal life. Particularly drawn to innovations that refine and substantially improve existing techniques. At this point, I'd like to discuss scleral buckling using chandelier illumination. Scleral buckling surgery typically relies on indirect ophthalmoscopy for retinal visualization with inverted image. However, the new approach utilizes surgical microscope and chandelier lights to effectively illuminate the periphery. The non-inverted image facilitates easier surgical execution, and we can 25 gauge and 27 gauge chandeliers can be used for these tasks. This innovation represents a fresh perspective on a long-standing procedure, and it has the potential to improve our surgical outcomes. Another innovation is the 3D heads-up display. Large screens and 3D glasses allow surgeons to observe the surgical field in greater detail and with less strain on their bodies. Not only does the surgeon benefit from enhanced visualization of the fundus, but the entire surgical team also gains clear view. This aids scrub nurses and serves as a valuable teaching tool for aspiring surgeons. Being a digital technology, the image can be further enhanced and improved. Contrast, colors, and depth of focus can all be digitally manipulated. We can even superimpose data from other devices such as OCT or angiography to construct a virtually enhanced image of the retina and vitreous, providing the surgeon with more information than traditional methods. This technology is undergoing continuous improvement, and we can expect to see even more benefits in the future.
Noteworthy advancements in displays and surgeons' viewing system is heads-mounted displays. These are similar to heads-up displays but project a 3D image on the surgical field directly onto the surgeon's eyes, providing even more immersive experience. This allows for the superimposition of data from other tests such as angiography or OCT. While still in the early stages of development, heads-up mounted displays hold the potential to revolutionize retinal surgery. Another innovation in ophthalmology is intraoperative OCT. OCT has been known for over 20 years, and its importance in retinal diagnosis is well established. When an OCT is mounted on an operating microscope, it becomes intraoperative OCT, providing surgeons with real-time cross-sectional views of the retina during surgery. This technology allows them to perform the surgery more safely and accurately and to respond promptly if complications arise. The surgeon can easily identify any complication and take corrective actions when needed. This makes the entire surgery even safer. We are seeing continuous advancements in scan quality, resolution, and imaging speed, with plenty of exciting developments on the horizon. There is still room for improvement, but intraoperative OCT is already revolutionizing retinal surgery, enabling safer procedures and better patients' outcomes. Now I'd like to discuss something incredibly exciting, robotic vitrectomy, which represents the next frontier in ophthalmology. Robotic surgery aims to counteract challenges that surgeons often face, such as fatigue and tremors, which can impact precision. Additionally, traditional instruments can have limited maneuverability due to the confines of the human hand. Robots have the potential to access hard-to-reach areas within the eye, expanding surgical possibilities. Surgery, particularly in ophthalmology, is a demanding task. The learning curve for such intricate procedures can be steep. Robots offer the potential to expedite training. Robotic vitrectomy holds great promise in multiple areas. Robots offer tireless precision, minimizing tremors and expanding the range of motion within the delicate eye. Furthermore, robotics opens doors for remote surgery, telesurgery, and remote mentorship, facilitating surgical training and collaboration. We are likely just scratching the surface of robotic vitrectomy's benefits, with countless possibilities yet to be discovered. Please imagine a future where complex eye surgeries are performed with unprecedented accuracy, where geographical barriers are overcome through telesurgery and where surgical training is accelerated through robotic assistance. This is the thrilling potential that robotic vitrectomy holds, a future where technology and human expertise converge to improve patient outcomes and revolutionize the field of ophthalmology. On this slide, you can see the only commercially available robotic surgical system for ophthalmic procedures, Precise Eye Surgical System from Carl Zeiss Meditech. This system operates on a telemanipulation platform where the surgeon controls a joystick that guides two robotic arms attached to the operating table. The system also includes an electric-powered headrest to ensure precise alignment of the robotic arms with the patient's eye. Notably, the Precise Eye system offers a remarkable 10 to 20-fold increase in precision compared to manual surgery, making it an available tool for delicate procedures. Its success has been demonstrated on human patients, particularly in membrane peeling and subretinal plasminogen activator injections. Here I'll be discussing a prospective study that evaluated the use of robot-assisted epiretinal membrane peeling. This research was carried out in Switzerland. Two experienced vitreoretinal surgeons performed the epiretinal membrane peeling procedures after receiving a comprehensive training in the Precise Eye surgical system. The patient's cohort included 9 eyes from 9 individuals, and the primary reason for surgery in these patients was visual impairment caused by an epiretinal membrane. In 4 of these cases, phacoemulsification and intraocular lens implantation were also performed. All surgical procedures were conducted under general anesthesia. They meticulously collected all the data on various aspects, including preoperative preparation time, the duration of the surgical intervention itself, and the surgeon's subjective feedback through questionnaires. These findings were quite compelling. It demonstrated a significant reduction in both preoperative preparation time and the duration of the surgical intervention itself when using the robotic vitrectomy system. Interestingly, a clear learning curve was also observed, suggesting that with increasing experience, surgeons can further optimize their efficiency and potentially reduce surgical times even more. The surgeons who participated in the study reported positive experiences overall. They found the robotic system easy to use and appreciated the reduced stress levels associated with robotic assistance. Notably, none of the surgeons reported any hand or arm strain, underscoring the ergonomic advantages of this technology. In fact, the surgeons expressed a strong desire to continue incorporating robotic assistance into their surgical practice. These findings offer encouraging evidence for the potential of robotic vitrectomy to enhance surgical efficiency. 3D heads-up displays and robot-assisted surgery will soon transform retinal surgery, creating a new era of digital operating rooms. Gene therapy represents a monumental leap forward in ophthalmology. Luxturna, the first FDA-approved treatment for inherited retinal disease, is a prime example of this innovation. This therapy utilizes a viral vector to deliver functional RPE65 gene, enabling the production of a crucial protein. Administering the drug requires subretinal injection in the macular area, a delicate procedure that I will demonstrate in the next slide. Here in Poznań, we have already successfully treated 3 patients using this gene therapy. Here, the critical moment of Luxturna administration. A delicate subretinal injection is performed using an ultra-fine 41-gauge needle, carefully delivering 0.3 cc of the medication beneath the retina. You can observe the fluid gently spreading under the fovea. In this particular patient, the outcome was remarkable. His vision improved from mere hand movements to 2/50. This exemplifies the potential of gene therapy for patients with inherited retinal disease. While we have made progress, there is still much to do in vitreoretinal surgery. We don't fully understand PVR, proliferative vitreoretinopathy, making retinal detachment prevention difficult. Pediatric vitrectomy needs better ways to remove the vitreous and to treat congenital defects. These are, in my opinion, the main big challenges. Innovations in vitreoretinal surgery lead to safer and more effective treatments. It is our responsibility as eye doctors to stay informed about the latest advances and guide our patients toward the best possible options for their individual needs. Here are the articles that contributed to my presentation. I encourage you to explore these for a deeper understanding. Thank you.
Dziękuję Marcinie za znakomitą prezentację.
Thank you very much, Marcin, for a wonderful presentation.
Dostaliśmy jedno pytanie.
We got one question on the chat. It is not related to the presentation per se, but I strongly encourage you to ask questions about the presentation. The question was about obtaining the certificate after the conference. If you would like to do so, if you would like to have that, please refer to the foundation. Send us an email, we will reply accordingly. And now, getting back to the topic.
Dodam, że zastosowanie luxturny to
Let me just add that the use of this luxturna procedure was the first time it happened in Poland.
Czy od tego czasu były kolejne?
Has there been any further procedures from that ever since?
Tak, obecnie podaliśmy lek 3 pacjentom.
Yes, currently we have administered the drug to 4 patients.
I obecnie przygotowujemy się do podania u 4 z
we
pacjentów.
are preparing to perform the procedure
rzeczywiście
in the 4th patient.
Jest grupa chorych w Polsce,
So there is a group of
która jest pod naszą opieką
disease patients
i
in Poland that is under our care, and
chcielibyśmy ostatecznie móc pomóc.
that we would like to assist and help with this procedure.
Ja chciałbym dodać, że
Let me just add
leczenie,
that this form of treatment requires a very precise administration of the drug, subretinal administration, and this is one of the elements
czy za 5, czy za 10 lat,
maybe 5 to 10 years for me or subsequent surgeons to be able to use robotic assistance here. Tremor is key here, of course, so we need to penetrate the retina a couple of hundred micrometers and administer the drug precisely between the subretina and epiretinal membrane.
Tutaj rzeczywiście korzystanie z wsparcia za pomocą
robotic support would be of great importance. So we reduce the tremor significantly, which would allow us to obtain better, more successful surgery. So this is what awaits us for sure.
Tutaj Andrzej, dostałem od ciebie
Professor Grzybowski
zadanie, żeby przygotować
asked me to prepare a presentation on that given topic, and among many exciting things, robots are definitely something which is the most creative and giving us the possibility of combining something you are expert of, AI. So us, in the future, we we are going to be excluded from the very process of the surgery. That's how I imagine it. So we have autonomous cars. First, roads were observed and analyzed by different systems of analysis. Then we excluded the driver, or we are going to do so. And then if the hands of the surgeon are not going to be needed in the future, then I assume so, because, well, tremor and tiredness are our main enemies. Robots do not tire, and the tremor is practically non-existing or virtually non-existent.
I do tego dołączymy
And if we add that to combine it with educated AI algorithms that will be able to make intraoperative decisions, then our contribution would be none. I don't know. What do you think? Is it the perspective of 3, 5, maybe 10 years? What is your opinion about the expert? As the expert, I think it's a bit longer than that, which is good news for us, I guess, surgeons. Robotics has two faces, I'd say. On one hand, it replaces a surgeon completely or a doctor completely, and in places when it is used by the operator. I think that robots will completely replace humans only in selected aspects. And first, we're going to have the stage of, let's say, cooperation between a human being and a robot. So with the inclusion of an expert that will know how to react when something unexpected happens, because this is the biggest problem with AI or other automated systems that would have decision-making trees programmed that are not always able to react like human beings. I think this is the primary problem. Similarly to AI, autonomous systems are quite few, I would say, and not a lot of people still want to give their fate into the hands of the AI. However, AI is definitely much more often used as supporting the decision. AI, well, is definitely something that we need to think about, and of course has further challenges. Well, the question is, for example, if the physician would be able to oppose an AI's decision. But still, the responsibility is in the hands of a physician, I would say. Maybe we will be able to create legal regulations if you were to rely on AI. AI needs to be legally responsible for that. We don't have that as of now. So first, these robotic systems will be used by experienced surgeons. Thanks to that, they will be able to do more, not more surgeries per se, but they would be able to do more complex surgeries. And maybe young surgeons will be able to enter the field of surgery earlier. So simulators, for example. Yes, for me it's an amazing aspect. I'm coming back to AI, and when we become aware that you, I, or other surgeons that operate on an ongoing basis, they will maybe operate, I don't know, 30,000 patients, so they have their experience based on this amount of surgeries. If we think about AI that can be trained in surgery using all the surgeries being performed throughout the last couple of decades, millions of cases that can be used for training AI, and such AI will be properly more experienced than any surgeon there is. And returning to the topic of training, and something that is also incredible for me, in robotic surgery, it's known, we don't feel that in ophthalmology, I would say, but a surgeon doesn't have to sit at the instrument. They don't even have to sit in the next room. They can be in a different country, different continent, which is amazing. because these most complex procedures we can use remote training by a person who is on a different continent, of a group of given to a group of less experienced surgeons. Hopefully we will experience that. Where there are first procedures being performed like that. A couple of years ago, my colleague Igor Kozak, Slovak doctor working in Moorfields Eye Hospital in Abu Dhabi, he conducted a laser telesurgery. So lasers are perfect for that, for remote surgeries, and it is possible currently in terms of telemedicine. This, of course, requires a very good online connection, because, of course, any distortion in network coverage could lead to serious consequences. So that's a challenge. But still, definitely telemedicine, not only diagnostically, as we had it, right, as of now, but also surgically, gives great opportunities, for sure. I have to conclude our discussion, and I would like to thank you for a great lecture, and I wish you all the best, further success. You're the pioneer in terms of Luxturna injections in Poland and very complex procedures, vitreoretinal procedures. Thank you very much, and you are the pioneer in terms of AI, so we're waiting for new systems that would be training itself and helping us in ophthalmology. Thank you very much. Ladies and gentlemen, now session 1.
Good morning, everyone. My name is Adam Bulengała. I work at the Silesian Medical University in Katowice in Poland. Today I would like to share with you my presentation on advanced diagnosis of dry eye syndrome with the use of innovative dry eye diagnostic device that is called Sediak from Quantel Lumibert company. When it comes to the treatment of dry eye, well, we can say that we certainly are not lacking many therapeutic options, because on one hand we have a lot of artificial tear eye drops containing many different preparations that are available on the market. Well, on the other hand, we already have medications that are designed to reduce inflammation, such as cyclosporine, but we also have antibiotics in tablets in a situation when someone has inflammation of someone has a blepharitis, for example. We cannot forget about omega-3 fatty acids, which are typical dietary supplements which can help, and we have a lot of eyelid preparations for washing the eyelid in treatment of the MGD, and of course we have devices to express the main bone for decongestion, such as C-steam or for IPL. So as you can see, in terms of therapeutic options, we have a lot of options, but in terms of diagnostics, it's more difficult. First of all, on one hand, the patient tells us about the symptoms, and based on that, we can diagnose dry eye. Based on the medical history. Unlike retinal diseases, where patients have very similar symptoms, but the diagnostic option is actually very simple, because what we do is just OCT and angiography. If OCT, we can do angiography, and then we will already have the result. We can see what's going on in the layer, and the case is obvious. It's the same as in neuro-ophthalmology. In neuro-ophthalmology, the patient tells us exactly what are the symptoms, and we can diagnose the same symptoms, for example, double vision, but the reason of that, well, it's difficult to examine. We have to do a lot of examination, a lot of tests, and at the end we still don't know. So in dry eye it was the case. It was easy to make a diagnosis. Well, you have dry eye, but the reasons for dry eye, well, it's a bigger problem to determine them. And the basic thing that all the therapies I showed you here, well, we need to match them to a given patient. Well, for a very long time, in terms of diagnosis, these options were narrowed down to the slit lamp examinations. We could use some staining there. Then later on, we had placido disc method. We could see the exact shape of the tear film. We could also count many different parameters. And we had questionnaires. Maybe they didn't give us the exact information, what is the reason of dry eye, but they stated the severity of dry eye. And we could compare this severity changes for the patient over the follow-up visits, and if our activities actually make sense. So here we have the fundamental problem, how to perform complete and accurate diagnosis of dry eye syndrome and not waste the entire hour for that. Well, the answer to this problem is CDIAC device, which is an automatic platform, and in 5 minutes it allows us to perform all these basic parameters, check them. It counts them. We don't have to mark anything like in many other devices. Everything is automated. That's why we save a lot of time and we get really reliable results. So actually, a CDIAC device allows us to, on one hand, measure how the patient blinks, to measure the break time, the thickness of the lipid layer, the thickness of the meniscus, to visualize the Maybom glands. But we're also able to, for example, take photos just to see how the eyelids behave, let's say. We can also measure using the scale, and we can also use the questionnaires, because this camera, as you can see, has also a tablet. And the patient can simply fill out the questionnaire and everything will be calculated and attached to the final report. And this is how the report looks like. And here what's very important, that we also have the scale. That is, everything is clearly shown in reference to some normative base. Here we no longer have to wonder whether this is good or bad. It's presented on the graph. Now you may ask yourself, why do we need so many parameters, 5 parameters to evaluate dry eye? Well, the answer is quite simple. Well, dry eye, it's let's say an umbrella disease, a big tent, and many different diseases are in this tent, under this umbrella, but there are many different reasons. For example, lipid layer deficiency, we may have aqueous layer deficiency. Of course, they are related in a way. We can also have some problems with the Maybom's glands. We can have inflammation. We can have problems, for example, with nematosis. So, we have a patient with dry eye, then first of all we need to identify the dry eye, and that's why we have the interview, questionnaires, we can see how it's staining, and then when we already identify dry eye, the second problem is its classification. So on one hand we can have, for example, tear meniscus that is too small, and which is related to the fact that we have too little aqueous layer, but we can also have Maybom's gland insufficiency, too little lipid layer, too few blinks, then we will have a problem with dry eye evaporating. We have a problem with evaporation of tear film too quickly. As I said, this camera is fully automatic. It means that we don't have the same problem like when we mark the Oxford scale to determine corneal damage. well, which is very subjective. I mean, if there are two physicians, for one physician it will be two, for the other three, for the other physician 3 will be like 2. Here we don't have this problem. This device is objective and independent of the operator. And all these tests and examinations are later calculated thanks to the use of AI. And the device also can tell us if a given value, if a given parameter is problematic or not. I will show you this later in the report. The camera will show you that there is a problem with, for example, the lipid layer or with the meniscus or with the instability of the tear film. Another advantage is that this technology is really advanced. Most dry eye measuring devices are very similar to each other. Here, well, we have several innovations that I'm going to show you. Well, the first and I think the most interesting is the imaging of Meibomian glands. In traditional mammography, we use infrared. Here, we not only use infrared, but also transillumination. And please see for yourself these glands, how they look like. Well, because of this additional transillumination, you can see much better contrast. We can easily find these glands, and the basic issue is that, well, the camera calculates these glands. So we have to have a very high resolution image to be able to be objective and to count them objectively, and it has to be repeatable. If we have poor image at the beginning, then the result will be calculated wrong. Such an accurate imaging of Meibomian glands is not only important for the calculation of their surface, it also allows us to tell something about the vitality of the glands. Why is this so important? For example, if we have the Meibomian glands plugged up, then we know that we should use IPL, heating, and then we need to decongest the glands. This is the basic method. But if we see that there are a lot of telangiectasias around Meibomian glands, then IPL is enough. But if we don't have telangiectasias and we don't have plugged glands. But if we, for example, have gray glands on this transillumination, we have little sebum, and the expression of these Meibomian glands will not tell us a lot about the treatment of the patient. Then we need to simply use IPL. So we see that high quality doesn't always translate into good reproducibility of the machine, of the device, but it also gives us a lot of information. What can we do for a particular patient? A comparison of mammography that is standard, infrared only, and infrared plus transillumination. You can see the difference. You see the ease with which we can detect the glands, and we can also see the more sebum, the darker. So the Meibomian glands are plugged somewhere. Another advantage of this device is that placebo is actually measured not in infrared, but in white light. These are two reasons why it should be measured in white light. First of all, we don't know if patients doesn't behave differently in a dark room, and we have only infrared. It's likely that the patient may stop blinking or blink less. The patient will behave differently than in white light. This is the first thing. So the white light is natural, and it gives us an objective result. But the next thing is that it is a more accurate method. When we compare it to placebo in infrared, it is often that the circumference is not well imagined. The first tear film break is most often happening at the periphery, so it's important to have a good imaging to be able to calculate this accurately. All these results that I've presented are in the report, of course. We are able to print it out, hand it to the patient, and also show it. The tablet I showed you is to show the patient everything on the screen, everything is clear, everything is visible. What's more, the device based on AI also provides us with information on how to interpret these results. As you can see here, when it comes to the tear film stability, it's severe. When it comes to meniscus, it's in a way average in this particular patient. And of course, another innovation. So the fact that the patient can actually fill out the questionnaire on the tablet, on the device. That's why we collect everything automatically to the device, and we are able to compare all the data during follow-up visits. What is really the most important thing here in dry eye is the monitoring of the patient. Thanks to the fact that all the values, as I said, have been calculated automatically, they are objective because the machine does it, we are able to compare everything. We just insert all of the data directly to the report. We can also compare results of the questionnaires. That is also very, very convenient. At the end, I would like to summarize CGYANG platform. Here we have all the tests that we need to diagnose the cause of dry eye. Actually, we can do it in 5 minutes. The image is HD, so we are able to obtain the result that is reproducible and repeatable. The device is really, really innovative due to the use of transfer illumination, thanks to the use of a tablet that also allows the patient to fill out the questionnaire, and thanks to the placebo measurement in white light. Additionally, everything has great friendly software that allows everyone to easily perform it and interpret results due to the fact that the device even gives us the final diagnosis. Thank you very much for your attention.
Thank you for your kind invitation, Professor Grzybowski. At first, I would like you to introduce the term of minimally invasive glaucoma surgery. This definition was first introduced in 2012 with article that proposed the group of procedures that share 5 common features. These are up internal access through the clear cornea, sparing the conjunctiva. They are also minimally traumatic to tissue. The expected intraocular pressure effect is suitable for low invasiveness of these procedures. They have also high safety profile in comparison to other anti-glaucoma surgeries, and they have rapid healing with minimal impact on patient quality of life. Since then, the glaucoma surgery was divided into microinvasive glaucoma surgery and to the traditional glaucoma filtration surgery. Are the mix common? I think yes, because in 2013 there was a research which showed that 1/3 of annual glaucoma procedures are mixed. And then 5 years later, in 2018, the amount of mix rose to 2/3 of annual glaucoma procedures in USA. This rise in mix has been also accompanied by a concomitant decline in traditional filtration surgeries. The most common procedure from the mix is iStent. There are 3 types of iStent. There is iStent first generation, iStent Inject W, and lately introduced iStent Infinity. They were developed for patients with primary open-angle glaucoma and pseudoexfoliation and pigmentary glaucoma. This microbypass is designed to support the natural outflow pathway. It is implanted into the trabecular meshwork, which is the site of greatest resistance to the outflow of humor from the eye. And iStent first generation has the shape of L letter. It is designed with a pipe-shaped inlet in the anterior chamber and truncated and fixed in the trabecular meshwork. Its dimensions are about 1 millimeter, so it is the smallest implant used in the human body. Although it is so small, the mathematical models indicate that the outflow of aqueous humor will be big enough to lower intraocular pressure after the procedure. Separate iStents orientation are available for the right eye and the left eye. It is made from heparin-coated titanium, and it is conditional to MRI scans. It means that patient can be scanned in the MRI up to 3 Tesla. Another type of iStent is iStent second generation. Similar to iStent first generation, is made from the same material, but the system includes an injector with 2 loaded iStents with a central entry and 4 peripheral openings to allow for the aqueous humor outflow for every direction. It is also implanted from ab internal approach. And lately introduced the iStent Infinity. It contains 3 preloaded intraocular stents. They are manufactured from the same material which the previous one, and also the iStent itself is has the same model, and it is the implantation is by the same technique. The differences is the model of the injector, because it's more easy to use and more safety to use for the operator. 3 implants are inserted into the trabecular meshwork 2 hours apart each other. And here you may see the image of enlarged iStents. What about the effectiveness of the iStents? More than 90% of our patients achieved intraocular pressure between 6 to 21 after 5 years, with or without medication. 64% of patients was medication-free. The average reduction of intraocular anti-glaucoma medication was 67%, and the average intraocular pressure was on the was 16.5. The reduction after procedure of intraocular pressure is not so big; it's only 25%. But the main focus in this procedure is more on reduction of intraocular anti-glaucoma medication than the intraocular pressure itself. Regarding to the complication, the most common complication is hyphema. There may be also some IOP spikes, keratopathy, cells in anterior chamber, stent obstruction or dislocation, and corneal edema, which is much more connected with the phaco itself. themselves. What is important about these patients? We have to remember that more than half patients with glaucoma have ocular surface disease. And after this procedure, decreasing in the medication burden leads to the alleviation of subjective patient-reported measurements. And in our study from 2021, before medication, before surgery, every patient receives some medication, and after implantation of eye stent, 74 patients from the group of 108 was medication free. Before surgery, 52 patients was on one medication, and this number decreased to 17 after the surgery. 28 patients was on two medication, and after surgery it was only 8. 70 patients was on free medication. After surgery, none of them received free medications, and 4 medications received 4 patients before surgery, and this number declined to 2 after the surgery. In my opinion, this is the best choice for patients with cataracts and coexisting glaucoma qualified for elective cataract surgery, moreover for non-cooperative, intolerant for anti-glaucoma eye drops, patients with control IOP with side effects on topical medications. Another mixed device is goniotomy with Kahuba dual blade. This special knife was designed to remove trabecular meshwork while minimizing damage to the surrounding tissue. It consists of a sharp blade for easy access to the Schlemm's canal, which is inserted into the canal and cuts the TM. This is the look from the operating surgery, and this is the look like the hands of the surgeon are positioned during the surgery. Here you may see the cliff which can be seen in the gonioscopy after the removal of trabecular meshwork, and here the OCT image of the anterior chamber. On the left hand side, the trabecular meshwork is cutted and the angle differs from this one on the right hand side. What about the effectiveness of these procedures? More than 60% of patients achieve target pressure with medication or without, and 46 patients without any medication. The reduction in medication burden is also very good. It's between 47 and 87%. Mean intraocular pressure after surgery is 15.5, and reduction in intraocular pressure is between 20 and 24. Regarding to the complication after the surgery, the hyphema is much more common. It occurs in up to 40% of patients. Other complications, it may be like IOP spike, corneal edema, cells in anterior chamber, iris damage, the cement membrane damage, or ciliary body cleft. It is the best result of this procedure is intrabecular glaucoma, like pseudoexfoliative glaucoma, pigmentary, inflammatory, or steroid glaucoma, when the deteriorated tissue is removed. The indications are very similar, like in eye stent, so I prefer this procedure in patients with cataracts and coexisting glaucoma qualified for elective cataract surgery, also non-cooperative, intolerant of anti-glaucoma drops, patients with controlled IOP with side effects of topical medication. And another latest device is canaloplasty ab interno with OMI system. The ab interno technique involves making at least 2 corneal incision and incision of Schlemm's canal. And after the performing a goniotomy, the eye track is inserted through the goniotomy side at the angle and up to 60 degrees from interior to superior into the Schlemm's canal. During the catheter insertion, the surgeon observed the illuminated tip of the catheter. And after passing the Schlemm's canal, we can also perform ab interno trabeculotomy on the angle which we desire. And at the end, I would like to mention about pressure flow microshunt, which is not exactly mixed procedure. It's more like minimally invasive bleb surgery, but it's, I think, very interesting proposition from the patient with advanced glaucoma. It used the principle of trabeculotomy without additional surgical complexity. It means that during this procedure, we do not create the scleral flap, trabeculotomy, iridectomy, or there is no suture placement on the flap. It is no need, but can be combined with cataract surgery, and comparing to the trabeculectomy, it has shorter learning curve with similar efficacy to the trabeculectomy. It uses the same, it bypasses the conventional aqueous humor outflow. It uses the same pathway for outflow as trabeculectomy. What about effectiveness? It's much more effective than traditional mix. More than 80% of patients has intraocular pressure between 6 to 21. More than half of them is without any glaucoma medication after the surgery. The average reduction in anti-glaucoma medication is 72%, and average intraocular pressure is 20.4. Reduction in IOP is between 23 and 38%. But the rate of complication is also much highest than in the previous procedures. What is the difference? What is interesting in this procedure? The position of the filtering bleb is much more is different than in the trabeculectomy, so the is less likely to fibrose after the procedure. In my opinion, this is the best choice for older patients because the shorter procedure time, fewer post-operation visit. Also for patients wearing contact lenses, and this one in which drop anesthesia is necessary because it can be made on topical anesthesia. Thank you very much for your attention.
Good afternoon. Thank you, Professor Grzybowski, for invitation. I would like to share with you my experience and say a couple of words about innovations in DMEC surgery. I have no financial interest related to this talk, and at the beginning I would express special thanks to Professor Marek Rękas, who visited us a couple of times and taught us how to start with corneal surgery. And also, without support of the authorities of our hospital, we will be not able to move on. So the corneal transplantation have been around more than 100 years, and actually through this 100 years, whatever we had problem with epithelial, stromal or endothelial pathology, we have always the same solution. So full thickness peripheral transplantation, and the research at that time was actually limited to what kind of suture we have to use, if it should be interrupted suture or double running antitoric suture and so on. And at the beginning of 21 surgery, one man started to think out of box, and it goes to Gerrit Meller, and actually surgery changed. So one we started to think out of box, the things exploded, and we have the surgery changed to DLEC, to DSEC, automated DSEC, DMEC or PDEC. It's not stopping there. I don't think so it will stop at all. The future definitely goes to cultured endothelial cells, and Professor Kinoshita have done a lot of work, and he sells actually his patent to Arion Biotech, and the Japanese name of the suspension, because this is suspension of cultured endothelial cells combined with rheokinase inhibitors, it's called Visnova. And if you put nanoparticles in that, so actually you inject this suspension, you ask the patient to keep the right position, face down, prone position, couple of hours. If you combine it with the metal cells, the nanoparticles of the metal cells, and if you put contact lens with metal, the patient even don't need to keep the right position. It calls M cells, and also the same concepts goes to the kind of gel, which is also combined with rheokinase inhibitors and cultured and human cultured endothelial cells, and it will be produced by a company named OcuCell. But concerning the innovation in DMEC, nowadays DMEC is a gold standard. I tell you later on why. But the innovations in DMEC surgery actually started more than 10 years ago, and this is started from Professor Mouraine from France, which basically tried to simplify DMEC surgery in order to introduce DMEC lamella in that way how we do it in DSEC. Basically it goes, we prepared the DSEC, the Descemet membrane the same way, we covered it with the metocell in order to avoid rolling of the lamella endothelium out. So we do it endothelial in, and we introduce in the anterior chamber. And actually it's not so popularized, and it doesn't convince me in the surgery itself, but what does convince me, it's the same way how we provide the transplant. Because when we will have endo in DMEC, which actually it's already available in United States, in Lions World Vision Institute. So this is much more safer, at least for the cells, than the way how we do it now. So every innovation has its rules, so it has to have better outcome than the current technique, and should be user-friendly, so easier to perform. And this is actually, we can see it in the graphs when we look at the number of keratoplasty procedures in the United States, exactly at that time when the banks started to prepare the pre-cut DSEC or DMEC, the number of procedures increased. So nowadays we have, when we introduce the DMEC lamella into the eye, or when we receive it from the banks, we have endothelium outside the Descemet membrane inside, which of course they can be more damaged than we do it in the other way. So we introduce the DMEC lamella exactly in the same way, so endothelium outside, and we have to correct the transplant in the right way, tap the cornea from above, and this is the way how we enroll transplants. So imagine the situation, which is actually currently available in States, and in the Middle East they can order that kind of delivery system, that we have Descemet membrane inside, that outside, and endothelium inside, and we can introduce, just like Mouraine proposed 10 years ago, in that way that DMEC tissue will naturally unfold into natural position. this is possible, and I think it's right and it makes sense. This is how it looks in the United States. The transplant has to be squeezed, otherwise it will unfold. And if you look at the cross-sectional image of OCT, you can easily recognize that this is the right position of the transplant. This is the endothelium inside and descemet outside. So to enroll something like this seems to be much easier, but I have no experience with that. Why we need DMEC actually, and why DMEC should be the gold standard instead of DSEC? First of all, because I've heard a lot of time, at least in my country, why we should perform DMEC. DSEC works also very well, and I have actually no power and no force to change it. But when we look exactly at the pathology, there is always a posterior corneal stroma in DSEC surgery. This is the reason also why the rejection rates after keratoplasty are so low after DMEC surgery, so lower than 1% comparing to 12% to DSEC and 11% to PK. But when we look exactly at the pathology, there's a big difference between Fuchs endothelial dystrophy and bullous keratopathy. So if we take Fuchs endothelial dystrophy, they both, whatever DSEC, even PK or DMEC, they have very high rate of success. But when we take only bullous keratopathy rates are low for both DSEC and PKP comparing to DMEC. There's an excellent work from Donald Tam. This is from the group from Donald Tam from Singapore, who definitely show us, this is over 300 cases, 300 patients, 300 eyes, that when we have Fuchs dystrophy, the results are similar, almost 99% DMEC, 96% DSEC, and PK 73 cases. But when we take only bullous keratopathy, DMEC had the best graft survival of 95% compared to DSEC 65 and PK 47 patients. So we definitely need DMEC surgery for bullous keratopathy. To summarize, of course, cultured endothelial cells and product available ready on the market will be probably in the future, will be probably our future, but now we have to master DMEC. And we should keep in mind that almost all corneal endothelial diseases, or many of them, are associated with interruption of blood-aqueous barrier. So it means that when we put foreign material, which is descemet membrane with stroma, with DSEC, it's far more dangerous than we put DMEC because we increase inflammation. So this all complex cases should not be also excuse for doing DSEC only because doing DSEC is easier. They deserve DMEC. And I want to start with with our actually routine surgery when we need to combine cataract extraction and when we need to perform DMEC and that DMEC in the same session, like here advanced Fuchs keratopathy with residual corneal edema, and this is you know it very well, this is the Tassignon lens, so back in the lens, and the whole procedure. Why it's, in my opinion, and I love to do that, why it's better for DMEC surgery than conventional lens, even if this lens is hydrophilic. Because if you have very well centered posterior and anterior rhexis, you placed both capsule inside the groove around the lens. Remember that you end the surgery with the implantation of Tassignon lens, you end with the OVD trapped behind the lens. So it's trapped behind the visco agents, it's trapped behind posterior surface of the intraocular lens and anterior surface of the vitreous body. So actually we have a small vis a tergo which allows us to shallow the AC at the very moment of PDEC surgery, and we do it in a very controlled way. So once we introduce the transplant into AC, we can confirm the right position with the whatever Musuri sign on intraoperative OCT. You can immediately shallow the AC as much as you want, what is very important, and the rest is quite easy because you put the gas bubble to stabilize as third hand to stabilize this transplant, and you do tapping like Diri Zamer proposed it by a couple years ago, and this is actually the end of surgery. And this is the fourth case which I wanted to show you after Perseflow implantation with mydriasis, probably due to toxicity. This is a young patient, 40 years old, where probably, I don't want to go for details, but probably wrong concentration of lidocaine was used, and it caused corneal decompensation, mydriasis, and after that IOP spikes up to 70. So the pupil was permanently enlarged. So first of all, you have to, before DMEC surgery, you have to constrict the pupil just with normal way and do the DMEC surgery. In that case, we were able to achieve extremely good results, from hand movements to 0.3 at the 7 days post-op, as you can see here, and with all follow-up with the good intraocular pressure. The last case which I wanted to share with you, it's the technique which I learned actually from the Agarwal's group. Idea was to utilize young donors. We all know that the young donors are very hard to deal with it, more difficult to prepare it, and sometimes it's even not possible. And when I saw for the first time the technique, I saw, so actually it was presented 1 year ago during one of the meetings which I attended. I thought it's a really very crazy idea because you lost a lot of cells. But there are cases, I've done 2 cases like that, there are cases when you have no other option. This is a very advanced bullous keratopathy, and DMEC donor 45 years old. So it behaves like pencil, and it really sometimes it's very, very difficult to unroll it, sometimes even not possible. So in situation like this, that you lose your visualization because the cornea, even after removal of epithelium, get hazy, so you are not able to recognize the transplants. Actually, the only option which you have is to connect the infusion tube with the air and try to enroll the DMEC transplant with the reverse Sinski. I know it looks dramatically, you sacrifice the periphery of the transplant, but this is the only way how you can fix, and in that cases which I've made, it worked. So to summarize, the future belongs to cultured endothelial cells. DMEC is better, far more better, have far more better results in bullous keratopathy. We need safe and predictable way to transport of tissue, just in order to have better DMEC for better quality, and of course all complex, until we will have cultured endothelial cells, or complex cases deserve DMEC. Thank you very much for your attention.
The subject of my today presentation is treatment of conjunctivitis in the 21st century. Conjunctivitis is by far most common ophthalmological disease. The main causes of conjunctivitis are dry eye syndrome, allergy, bacteria, chlamydia, and less often viruses. Concerning bacterial conjunctivitis, the most common cause of this kind of conjunctivitis are gram-positive bacteria, especially Staphylococcus, Streptococcus. Less often there are chlamydia, although chlamydia infection are very often underdiagnosed. And gram-negative bacteria are much less common as a cause of bacterial conjunctivitis. First of all, there are Haemophilus and Moraxella, and other species of gram-negative bacteria are much less common as a cause of conjunctivitis. What do we have for the treatment of bacterial conjunctivitis? First of all, there are aminoglycosides, fluoroquinolones, and macrolides. Concerning aminoglycosides, the most effective of this group of, they are the most effective against gram-negative bacteria, especially Haemophilus, Enterobacteriaceae, and Pseudomonas. They are much less active against Staphylococcus. But they do not work against methicillin-resistant strains, and they are very weak against Streptococcus. Fluoroquinolones, their effect depends on the generation of this group of antibiotics. Strong effect they have against in all groups. They have against gram-negative bacteria, especially of Haemophilus strains, Salmonella, Neisseria, and Enterobacteriaceae, and Pseudomonas. Effect against gram-negative bacteria, gram-positive bacteria, depends on generation. They have very second generation. They have very weak effect on gram-positive bacteria. The best effect has fourth generation of fluoroquinolones, and some of them are also effective against chlamydia. Concerning macrolides, they are inferiorly broad-spectrum antibiotic, and they are active against gram-positive and gram-negative bacteria, also by anaerobes and chlamydia, while its effectiveness is best in the case of bacteria from the genus of Haemophilus and Moraxella. Its effect on Staphylococcus, especially on methicillin-resistant strains, Streptococcus, is limited due to the effect of rapid development of the antibiotic resistance. Enterococcus and Pseudomonas strains are resistant against this group of antibiotics. In summary, although all these three groups are broad-spectrum antibiotics, their effectiveness is the highest in conjunctival infection caused by gram-negative bacteria, but it is weaker against infection caused by gram-positive microorganisms, which is the most common cause of bacterial conjunctivitis. Fourth generation of the fluoroquinolones are the most effective on gram-positive bacteria. This consideration are confirmed by recent clinical studies which found a similar effectiveness of inflammatory cure in the group using eye drops with chloramphenicol and moxifloxacin in treatment of bacterial conjunctivitis, comparing with a group of receiving of placebo. Because of this weak effectiveness of antibiotics, is the main cause is antibiotic resistance. First antibiotic was discovered by the Scottish bacteriologist working in the St. Mary Hospital in London, which discovered in 1928 first antibiotic penicillin. It takes 14 years when commercial production of penicillin started. Behind this success was two other bacteriologists, Howard Florey and Ernest Chain, which isolated penicillin and started to develop the program of commercial production. In the next years, commercial production of different antibiotics started to develop, and in nearly every year, a new group of antibiotics was introduced on the market. The phenomenon of bacterial-resistant antibiotics was already foreseen by Jan Fleming, the discoverer of the penicillin. During his lecture, during Nobel Prize award ceremony at December 19th, 1947, he said, "The time may come when penicillin will be available in a store by anyone. There is therefore a danger that unaware person will take it in too low doses, and microorganisms exposed to an inappropriate doses of the drug will become resistant." Antibiotic resistance is now the third leading cause of mortality in the world, after cancer and cardiovascular disease. And in 2019, it was accountable for approximately 5 million deaths worldwide. It is estimated that in 2050, mortality due to antibiotic resistance will increase to 10, and some are saying that 20 million annually. Antibiotics resistance can develop when there is a contact of bacteria with antibiotic, which is very common. Only in Poland, it is estimated that approximately 4 million packages of antibiotic eye drops are sold annually. Second condition, it is repeated periods of sublethal antibiotic doses, which are caused by the weak effectiveness of the antibiotic, also not adequate doses, biocompatibility of the use of a treatment of conjunctival bacterial conjunctivitis by patients, and weak penetration into the tissues. It has been also described that even a single administration of antibiotic drops can increase the development of antibiotic resistance in bacteria. Therefore, is the use of antibiotics in bacterial conjunctivitis really the best treatment method, considering their effectiveness and the possibility of development antibiotic resistance? Since some years on the market, there are eye drops with antiseptics. The antiseptics are effective both against gram-positive and gram-negative bacteria, also against chlamydia, some viruses, acanthamoeba, and also against fungi. The effectiveness of antiseptics against different group of bacteria is more similar to the causes of bacterial conjunctivitis. As you see, antiseptics are more effective against gram-positive bacteria than gram-negative, bacteria, and also they are effective mostly against chlamydia. So therefore, how to treat conjunctivitis in the 21st century? What are therapeutic indications? First of all, a very large part of conjunctival inflammation, especially bacterial conjunctivitis, do not require treatment. Bacterial conjunctivitis usually have spontaneous regression after 7 days. So treatment with antibiotic can only shorten this period of time. And usually, after the bacterial conjunctivitis, there is no, for example, keratitis. So a lot of bacterial conjunctivitis can be left without treatment. The treatment should be started with antiseptics because of their greater effectiveness and lack of effect on the development of antibiotic resistance. One should not use antibiotics or combined antibiotic steroid therapy as a first-line treatment of conjunctivitis. If the treatment was not effective after 7 days of use of antibiotic, preferably in this situation, use antibiotic drops, preferably fourth generation of fluoroquinolones, due to the widest range of antibacterial action and very good penetration into the conjunctiva. If the cause of the inflammatory condition is known, like for example, allergy, dry eye syndrome, start causal treatment. In all other cases of not confirmed etiology, especially suspected chlamydial, viral, fungal, and amebiosis, start treatment with antiseptics. Thank you very much for your kindness and attention.
Dzień dobry.
No, actually. Thank you. Thank you for such interesting lectures. I would like to ask if there are any questions to our speakers. I have one question. I hope you can hear me. Professor, can you tell me how do you qualify in difficult cases when you have neovascular glaucoma? So how do you qualify patients for MIGS? And do you exclude any patients from canaloplasty, or you need to perform deeper, because you need to perform deeper procedures? Can you tell us more about that? How do you qualify your patients? Thank you for the questions. Yes, of course, MIGS are not to all patients. The main criteria that I use It's the advancement of neuropathy in glaucoma, because based on that we can assume what is the aqueous outflow. If the patient is a patient that takes a lot of drugs, that has been treated for many years, is between 30 and 40 years old, he or she is not good candidate for MIGS. MIGS are usually for patients with threshold IOP, with many defects in the visual field, and patients who actually do not tolerate anti-glaucoma medications or who don't want to take medication drugs due to non-compliance. So sometimes my youngest patient was 23 with early neuropathy in glaucoma. Thank you very much. During canaloplasty, how the collectors behave, can you predict if it will work or not? Yes, of course. It's a very good symptom intra-op. The reflux of blood to the, from Schlemm canal to the anterior chamber, and if this is happening during the procedure or early post-op, we know that the Schlemm canal was properly cleaned out and that we will have good IOP. Thank you. I would like to ask you a question. DMEC, is it a great solution to all patients, or maybe DSEC would be better for another patients? Well, well, in the pathologies of endothelium, yes, DSEC is better or easier, and maybe we don't lose so many tissue at the beginning. So people or operators who know how to do it, they don't want to risk it and they do DSMEC. But if we look at our neighbors from the West, there are clinics that for 10 or 15 years, they've never done DSEC. Everyone is doing DMEC. So this is a trend. Unless we have a ready preparation with endothelial cells, cultured endothelial cells, we need to learn how to perfect DMEC, especially in bullous keratopathy. Thank you. Thank you for your response. If I can, I would like to also cut in, because we have two questions on the chat, both questions to Professor Konopińska. How frequently do we have hemorrhage to anterior chamber when we have iStent implantation? The second question, is iStent implantation reimbursed by national healthcare? In terms of the first question and hemorrhage, I wouldn't call it hemorrhage. It's more like clot that happens in 20% of our cases after procedure. So it's 1-3 millimeters and it absorbs without any need to wash it out during 7 days. It's not the blood from the damaged vessels, from the cut vein, for example. There are no factors that would create fibrosis. This is just the secondary blood that absorbs quickly, so it's in 20% of cases. But in terms of the second question, yes, at the moment, the reimbursement of combined treatments in our clinic is 11,000 Polish zlotys. This is what is paid to the patient by the national healthcare. In implants, it's 4,000 Polish zlotys. If we are talking about the second generation implant inject, so yes, we have reimbursement, and then we have also cataract surgery. Then this is a procedure that is reimbursed, and hospitals even can profit on that procedures. Thank you. I have a question to Professor Prost, because there are more and more, we more frequently use antibiotics. Antibiotics are stronger and stronger. So what is your recommendation? Do you think that we should start with the use of antibiotics that have a broad spectrum, or before we have, for example, or maybe we should start with, let's say, milder, narrower activity of antibiotics? Well, we have to differentiate if we have blepharitis or conjunctivitis or keratitis. I don't do such bacteriograms because it's sometimes by accident. Several days pass before we get the result of bacteriogram, and that's why I don't think it's worth doing. If this is bacterial infection, then we need to start the treatment. If this is a small inflammation, bacterial inflammation, then we don't have to start the treatment at all. I practically now use antiseptics in bacterial conjunctivitis. Antibiotics are associated with resistance, and the efficacy to gram-positive bacteria, the efficacy of these antibiotics against such bacteria is limited, and gram-positive bacteria are the main reason of conjunctivitis. That's why I use antiseptic drugs that act better on gram-positive bacteria than the majority of antibiotics. But if we are talking about corneas, then this is another case, other story. Here, this is a disease that may lead to many different complications that may deteriorate the vision. That's why here we need to do examination, antibiogram, especially before we administered first eye drops, and then we start the treatment. It's not the topic for our discussion today, but usually when we have small ulceration of the cornea, we need to implement combined therapy, antibiotic, fourth generation. Maybe bacteriogram says otherwise, so then we choose another antibiotics. I'm talking about commercial antibiotics because we also have other strengthened eye drops, but at the same time we can provide patient with antiseptics that will complement the treatment with the and I think that the combination of antibiotic and antiseptic is the best. But there are no studies that would compare keratitis treatment that would compare combined treatment in keratitis. I'm talking about the combination of antibiotics and antiseptics. But I think the future lies in antiseptics because on the Polish market we have two very effective antiseptics, and the other two of lower concentrations are also very, very efficacious, and they give good results. Thank you. Thank you for this interesting voice, because we observe overuse and everything that happens in eye. We see that doctors administer antibiotics. Can you tell us what kind of antiseptics do you use and the regimen that you use? I use commercial preparations because in the pharmacy, if you want to make the drug, it's a complicated process. It takes a long time. Pharmacists don't always want to do it. Only a small amount of pharmacies in Poland does it. That's why I use commercially available preparations. I have two drugs like that I use most often. Ocucept, if I can say the name, if I can drop the name, and Pozodrop. Chlorhexidine, and the second one, ozonated acids. And I use these two. If the inflammation is smaller, we can add Keratosept. That can also be helpful in the treatment of the surface of the eye. But mainly these, the first two, because they have the higher concentration of antiseptics. Thank you. I think that the last question to Professor Konopińska. Do you think that the trabeculectomy will survive? Yes, I think yes, because there are many patients who require trabeculectomy, that this is the most frequent anti-glaucoma surgery around the world. But this number, it decreases, of course, but this is still standard, and we cannot forget about trabeculectomy. We still see its place among other anti-glaucoma procedures. Thank you. I received one question online. I talked about it. I already talked different names of preparations, but maybe I should repeat that. The most frequent one, Ocucept, chlorhexidine, Ozodrop, the second one, ozonated oil. Thank you. We have to finish the session. Thank you very much for wonderful presentations and great discussion. We need to now have a short break and we will start with the second session. Thank you.
Open your eyes to an entirely new world of possibilities in your operating room. Innovative digital and 3D technology have set new standards in surgical precision and are empowering healthcare professionals to deliver the best outcomes for their patients. We created Siluma with a single goal in mind: to change the way you look. Your surgery can be performed in 3 different ergonomic and healthy ways. The C-shaped suspension arm allows a direct view of the 55-inch 3D 4K monitor straight ahead, without having to twist your neck. To minimize the microscope footprint in your operating room, a stand-mounted 31-inch 3D 4K monitor can be used. The digital binoculars can be positioned more freely than optical binoculars, allowing you to take on an ergonomic posture while benefiting from all advantages of digital microscopy. Siluma optics are custom-made for digital surgery. They provide optimized depth of field to minimize the amount of refocusing, thus helping surgeons to maintain their focus on the surgical site and perform precise surgical maneuvers. Maneuvers like ILM peeling require accurate color reproduction and contrast to identify subtle differences in tissue color and texture. Siluma is your ultimate surgical companion, so you can focus fully on the surgical procedure. The operating surgeon can control all system parameters via the foot switch and an on-screen menu. The user interface on the e-rack allows for an optimized workflow and intuitive control by the surgical team. The ideal classroom assistant, Siluma transforms the surgical experience inside and outside of the OR by creating an immersive surgical environment. Offering real-time support via a touchscreen interface, the Assist Mode feature allows users to make annotations or notes on the surgical image, enabling cutting-edge collaboration during live surgery. With Siluma, ophthalmologists can now immerse themselves in a new surgical experience that is destined to transform the field. Siluma, the new dimension of fully digital visualization.
So I'll be talking about this new microscope, fully digital microscope called Siluma. I'm working at the Rothschild Foundation, the department headed by Damien Gattinelli. So what is full digital? If we ask ChatGPT, because we're talking about digital, what does he think about, or she thinks about full digital microscope? The answer is it's a technology that allows you to have a camera integrated into the microscope, so you don't have the optics, and it allows you to think about algorithm, about different things that you can integrate softwares to your microscope in order to increase and improve your visualization and see things perhaps that you would not be able to see with classic optics, or enhance some specific colors, or add some IA that would say, oh, watch out, there is something dangerous that you're doing here. So it opened the room for plenty of applications. How does this microscope work? So you have, with the Siluma, different options. You can work with the classical binoculars, but it is a digital binoculars, and it is it's very easy to use because you can position the binocular in the position where you are the most comfortable. You don't have to be like with your neck down. You can put them at 90 degrees, and this also opens the door to different option and position. It's much more ergonomic posture. And for glaucoma, for example, when you need to tilt, you don't need to reposition the microscope because there is an option where you can tilt. It can also open the door, for example, for toric IOL. When you want to do a marking, you can tilt your binocular, take some image, for example, and put it back without moving everything. It has also 2 monitors, and I will show this after. So you have the binocular first. And this, there is plenty of ophthalmologists that are raising now the awareness about how it's important to have a good ergonomy when we're working, to have a good, nice sitting position in order to avoid any pain to the neck, to the back. And this definitely helps a lot. You will see in the next slide why. Because with this microscope, there is a specific C-shape suspension arm that allows you to look at your screen without having to bend your neck or look at the right or left. You look just straight, and you have this big 55-inch screen that is positioned. You can position it at the end of the bed. Some surgeons prefer to position it a little bit closer, but here you have a very good visualization of what you're doing, and not only you are seeing very well, but all the people who are attending the surgery in the room are able to follow the surgery also in a very well way. So here is another image of the positioning. So this is a 55-inch screen, positions at the end, and you have the 3D glasses that allows you to see well. There is also another monitor, and this is also something very original and specific to this microscope, which is a little bit smaller, but you position it closer. It's positioned at around 80 centimeters from you. Again, we see through the C-loop of the arm. And I found this way to work more comfortable for me. Some other has found that the large screen was better, but for me, this closer screen gave me a better, a closer, I would say, visualization of what I was used to. And this is what I like it a lot. It has also a teaching module in which you can add different marking on your, because it's digital, so you can do whatever you want. Here, for example, in a DMEC surgery, I'm marking a circle on where I want to perform my trephination. If it's my fellow who is doing the surgery, I tell him, well, I want my trephination this size. I can change, adjust for the capsular axis, for example. Also, you can, so you can add, I mean, imagination is the limit of all what you can add as things on everything digital. I'll show you a little video also of cataract surgery. So I will not talk about the cataract itself, but in the first generation of those 3D microscopes, for those who had the opportunity to use them, there was always a kind of gap between the movement you were doing and when you were seeing the movement. And the first thing I was afraid about, to be honest, is to have the same. So to have some gap and delay between my movement and what I'm seeing. And I can reassure you on that. There is definitely no delay at all. You see instantly what you are doing. So you see here my positioning. I'm straight. My fellow is here, and I mean you have an excellent visualization of all the different segment of the eye. There is nothing that I could remember was more difficult. It's even better for me because I mean as you can see, I'm tall, and I had some back and neck problem, and being able to do a surgery while being just straight was very, very helpful, and I really appreciate it. So then you have the IOL insertion, and surgery is done. And I've performed cataract surgery, but I also performed keratoplasty and DMEC surgery with the microscope. And it was not an easy case. And again, visualization was really very, very good. So this is graft preparation. For those who are used to or who know DMEC surgery, I prepare myself my graft. So this is the scoring of the donor cornea. And the additional things that you can do is when I'm gonna put here vision blue to better see my desmet, there are some filters that are incorporated. Again, it's digital, everything is no limit. So with the filter, you can increase the blue visualization, so you can see better whatever is blue. So inside the eye, and I'll show you later on how we are able to see better the graft inside the eye, and this is also very, very helpful. So here is the graft getting prepared. This is punching, then peeling of the desmet membrane and endothelial cells. I mean, some people have the eye bank preparing their graft for themselves. I'm not so lucky, but I'm lucky to have a good microscope. So, and this is the next part of the surgery. So desmetorexis, again, so with this microscope, good visualization, no problem at all. Doing this desmetorexis. Here, for example, I marked my cornea because I'm used to mark my cornea, but you can imagine that we don't need anymore to mark the cornea because you can mark digitally the size of what you want to do, and you will be able to project it and see it. Here it is a vitrectomized eye. So in vitrectomized eye, I'll do a scaffold technique to inject my graft. So I put some 10-0 suture to inject my DMEC graft on top. So this allows me to have a shallower anterior chamber because in vitrectomized eyes it's a little bit more difficult to unfold the graft. But because there are those sutures, it makes like look like the anterior chamber is shallower, and I managed to. And here you can see the difference between when I added the filter. Here there was no filter. And now you will see with the blue filter, you can see much better the graft. And if you mark the graft, for example, the S or anything, you can see it better in order to unfold it and finish the surgery. So this is a case with a quite like clear cornea, but it can also be done on a less clear cornea. So the graft is like almost unfold here, and then putting an air bubble underneath in order to attach it to the posterior stroma, and then removing my scaffold suture when I'm done. And I thank you for your attention.
Dear colleagues, thank you very much for inviting me to speak at this conference. Today I would like to share with you my views on laser retinal treatment. We have come a long way since the first photocoagulator discovered, or let's say invented, by Gerhard Meyer-Schwickerath, which was not in fact a laser, but coagulator used for retinal diseases that used the sunlight. So it was, what's quite funny, dependent on the weather conditions, and used also heliostat to compensate for the earth movements. Now we use very compact semiconductor lasers with multi-spot modes and subliminal modes. When we look at the laser spot performed with the ruby laser, which was the first laser used for retinal photocoagulations, and the multi-spot lasers used nowadays, you see a huge difference. There was a quite significant retinal damage with these older lasers now, we see elegant, very evenly distributed laser spots. Nowadays, we usually use 3 laser wavelengths for retinal treatment. This is green, yellow, and infrared. We also use pulsed lasers in microsecond and nanosecond modes, but today I will rather concentrate on classic photocoagulations and micropulse laser. Multispot mode was introduced to our ophthalmological practice quite a long time ago. It's more than 10 years now. It was first incorporated in the Pascal laser. It's very convenient, it's very patient-friendly because it enables us to perform panretinal photocoagulation at one session. What's very important is that it causes much lesser pain sensations than conventional laser. Manchester Pascal study analyzed the effects of this laser in this multispot mode, and the researchers proved that it's not inferior to the panretinal photocoagulations performed in a classic way, let's say divided into 3 sessions. It causes similar or even better regression of neovessels. It also causes much less pain, and it also causes less loss in retinal sensitivity and visual field defects. To obtain the multispot mode, we have to use very short laser impulses and higher laser powers, so we shouldn't be afraid of that. It's how this laser works. When we speak about philosophies of laser interaction with retinal tissue, it's all about the parameters and also laser wavelength. So the classic supra-threshold photocoagulations causes the retinal scar as an endpoint. So we do it in supra-threshold mode. Subthreshold laser photocoagulation is used with the lowering of the laser power parameters. Usually the impact duration is the same, so it's 0.1 or 0.2 seconds. It causes limited destruction of retinal layers. True subthreshold non-damaging laser is subthreshold micropulse laser, so it's pulsed laser where the duty cycle, which is the effective time of laser action at the retina, is set at 5%. This is the safe, empirically set level. The whole pulse envelope is usually between 0.2-0.3 seconds. However, during this envelope we have very short impacts. It's the level of tenths of millisecond, between which we have the cooling of the retinal tissue, and this way we, let's say, eliminate any damage to the retina. Similar philosophy, but with different duration of the impulse, is endpoint management introduced by Topcon. And we also have completely different philosophy, which is associated with selective retina therapy and 2RT lasers. This is the philosophy of selectively targeting RPE cells, causing their destruction, and this way stimulating growth and proliferations of new RPE cells that work better. So it's so-called rejuvenations of the retina. But as I said, today I will concentrate on micropulse laser, which is the most commonly used among subthreshold lasers. Here is the visualization of the difference between the conventional photocoagulation and micropulse technology. We see that between the impacts we have the off mode, which means the time when the laser doesn't work. Why this idea even emerged? This is a slide board from our friend Victor Chong. When we look at the classic photocoagulation, we get the retinal scarring, which is a dead zone. But we have to think about the cells that neighbor this zone. They are under the thermic pressure, let's say. So the thermic pressure, thermic stress but not little one, causes these cells to elicit the HSP factors. So these are heat shock proteins. These are basically cytokines that have anti-inflammatory action. They also work sometimes similarly to anti-VEGF medications. They are generally independent on the laser wavelength. This is all about the energy to cause this elicitation. It has been proved also on laboratory animals that they cause prevention of cell apoptosis. They also improve macular perfusions, which was documented on the OCTA examinations, and also improvement in Miller cells function, the cells that, let's say, have very basic, let's say, structural function in the retina. How do we perform this laser? What is the technique? So first we have to determine laser power, and these are some controversies in that, because some of the researchers titrate, so do like a sample burn and then reduce the power, or some, like me, use low fixed power parameters. I think both philosophies are applicable. Duty cycle of the subthreshold micropulse is, as I said, empirically set at 5%, and this level is considered safe for the retina. However, larger values of duty cycle were also tried, sometimes with success, but we have to remember that our safety margin is narrower. What's important is the density treatment. As we see, this is high density treatment with spacing 0 between the laser spots. What are the disorders that we can treat with SML? It's central seroscleral retinopathy, both chronic and acute, diabetic macular edema secondary to retinal vein occlusions, and also maybe controversial subjects like application of SML in dry AMD, or preventing enlargement of geroid atrophy, or even treatment of inherited retinal dystrophies. There are papers that advocate use of this technique in these diseases. As I said, the protocols are subject of controversy. Here we present the recommendation of Retinal Laser Society Light. We see that this retinal, that the laser power parameters can be adjusted according to the therapeutic range of the laser. What is therapeutic range? Is the range where we get the elicitations of heat shock proteins. So when we think about this philosophy, we think that HSPs are elicited in on-off mode. So we do not have gradation. We rather either stimulate RPE or not. So this philosophy advocates fixed parameters. But when you look at the quantum medical recommendations, we see that this is different philosophy, because this philosophy advocates titration. So we get the, let's say, sample burn, where we get the slight grayish effect at the retina, and then we get low with the power parameters by 50% or even to the level of 30%. Let's have a look at the some examples of the successful SML treatment. First, let's start from diabetic macular edema. We have to think, in my opinion, about specific group of patients with good visual acuity. We know from the large randomized research that these patients do not benefit neither from intravitreal aflibercept or classic laser photocoagulation or observation. So the usage of all of these strategies gives similar, let's say, functional results. So this group could be quite a good group for subthreshold micropulse laser. How do we apply this laser? What are the indications? So there are two approaches. One basis on the best corrected visual acuity level, and Jeffrey Luttrell, who is our friend, who has the probably greatest experience in the world in micropulse, uses the level of let's say 0.5 as the threshold for either applying subthreshold micropulse or starting treatment with anti-VEGF injections. On the other hand, other researchers also bring up the level of the edema. Usually the 400 micrometers are treated as the threshold between which indicates either initiation of the therapy from intravitreal injections or starting from subthreshold micropulse laser. And here we see some successful treatment after subthreshold micropulse laser alone. Now, central scleral retinopathy. This is the entity where we have very good effects. We can obtain very good effects with subthreshold micropulse. However, we have to remember that nowadays our approach to this disease is a little bit different than the previous one. So now we treat this disease rather as simple or complex, depending on the alterations of the RPE visible in, for example, fundus autofluorescence. So we rather tend to use multimodal imaging to assess this disease, not the duration of the symptoms. And here is excerpt from our book, which we prepared also with Professor Grzybowski. So we see that in chronic cases of CSCR, usually the improvements in visual acuity are minor. However, singular singular studies show also improvement by, let's say, a few lines on the Snellen chart. I believe that it depends on the level of distraction of the RPE at the beginning of our treatment. Here are examples of successful micropulse laser therapy, and here is the table also from our book where we compare the PDT versus subthreshold micropulse. We know that photodynamic therapy is very popular in central ceros, and it provides great morphological improvement. But when we look at the chronic cases, again, functional improvements are similar, achieved by both PDT or subthreshold micropulse. In RVO, these effects are not that great. However, I would like to share with you my experiences with small retinal edema. I have very good results with residual edema in after retinal vein occlusions, and I would advocate this treatment. Not necessarily the anti-VEGF, but such a simple procedure and cheap as laser can help us achieve also BCVA improvement. So when we conclude about the vascular diseases and application of FML, we have to remember that it's better and safer than classic photocoagulation. It's also worth to combine it with anti-VEGF because we can reduce the burden of number of intravitreal injections. That's also important from the financial point of view. And at the end, I would like to mention the use of this laser in retinal inherited diseases as retinal degenerations. Our friend Jeffrey Luttrell has published a few papers that proved its effectiveness in improving visual fields and BCVA in retinitis pigmentosa, for example, also in slowing the progression of geographic atrophy in the course of dry AMD, and also he is using it also as a protective therapy against conversion of dry AMD to wet AMD. These are high quality studies, so I would recommend to look at them also. So thank you very much for your attention. I would like to encourage you to use this laser because it's very safe and it can give us a lot of satisfaction in the treatment of retinal diseases. Thank you very much.
Good morning. It's a big pleasure for me to discuss today the subject about simultaneous OCT and fluorescent angiography retinal imaging. We all know that nowadays it's an era of multimodal imaging of retina, and there are a lot of different modalities to illustrate the retinal pathologies. Multimodal retinal imaging is defined as the use of more than one complementary technique system that is used to acquire images. It works concurrently or in a short period of time for the purpose of diagnosis, prognostication, management, and monitoring of diseases. Multimodality imaging provides unique advantages to visual, anatomic, and functional information of pathologic conditions. I would like today to show you some cases based on the Heidelberg spectralis imaging with the use of module of simultaneous fluorescent angiography and optical coherence tomography. Fluorescent angiography and optical coherence tomography scans are important tools used in the examination and management of retinal diseases. These investigative modalities complement each other and in many situations require both imaging methods to make the correct diagnosis and treatment plan. Fluorescent angiography provides retinal circulation details, and OCT gives us high-quality anatomic images. However, fluorescent angiography is an invasive method, non-quantitative and subjective. Of course, the use is limited for patients with small pupils and insufficient media clarity. Optical coherence tomography is objective and is not so much affected by pupil size or media clarity. Registration of OCT scans helps clinicians properly assess patients during follow-up visits. Both diagnostic tools depend heavily upon patient cooperation. Both of these methods are used often complementary in the diagnosis and management of a variety of retinal disorders, such as age-related macular degeneration, idiopathic juxtafoveal retinal telangiectasia, myopic choroidal neovascularization, uveitic cystoid macular edema, diabetic macular edema, and central seroscleral retinopathy. Besides, several vitreomacular interface disorders are examined by these modules. Each modality has unique strength and weakness, and in the work of Kozak and her group, they analyze the discrepancy rates between intravenous fluorescent angiography and time domain OCT for the diagnosis of diabetic macular edema. And in this case, the sensitivity of fluorescent angiography was 98.7%, and with OCT, it was this sensitivity was smaller, and in 3.86% of eyes, they found that fluorescent angiography showed leakage in the macular area, but time domain OCT showed normal contour. Time domain OCT detected both intraretinal and subretinal fluid in the eyes, while fluorescent angiography failed to detect any fluid. The largest number of discrepancies was found while scanning the DME, and FA in this case was more sensitive than time domain OCT for these conditions. More than 40% of eyes with this pathology showed discrepancy. So fluorescent angiography and OCT showed different images concerning DME, but were equivalent when testing with modules for imaging of AMD, especially exudative AMD. Diagnosis of macular edema with fluorescent angiography and OCT is important in our diagnostic everyday practice. And we know, and it was improved by several works. And this now I want to pay your attention on the work of Barteselli and his group, which showed that fluorescent angiography was as sensitive as spectral domain OCT for the management of DME. However, on fluorescent angiography, the details concerning DME were better visible. Spectral domain OCT was more sensitive in the diagnosis and management of anatomic disorders rather than vascular disorders, in contrast to FA, such as macular holes. The work of Barteselli estimated that overall discrepancy between fluorescent angiography and SD-OCT was more than 4%. This discrepancy was greater in cases of diabetic retinopathy and uveitis. And as it was mentioned before, the highest agreement rate and lowest rate of disagreement was noted in AMD, especially in exudative AMD. Here, with the use of infrared documentation of a fundus, we can observe a normal fundus without any pathology, and at the same time, OCT, B-scan OCT was performed, showing the normal anatomical aspect of macular region. Here, the next example of almost normal retinal image of the central part of the macular region. However, in OCT-B, we cannot observe any pathology in infrared photo, but in OCT-B, we observe some degenerative areas in the subfoveal region and the detachment of the vitreous above the macular region. The subject of my today talk is the combination of fluorescent angiography and OCT as a simultaneous image. And here we can observe a normal image of physiological circulation in the macular region on the left side in fluorescent angiography, and on the right side the normal aspect of the macula on OCT-B. In such a pathology as central serous chororetinopathy, in OCT-B, of course, like in this case, we can see a typical image of subretinal fluid presence in the subfoveal region. In this case, the infrared documentation was made. But when we put some other diagnostic, more profound diagnostic with the use of fluorescent angiography, here we can see this presence of subretinal fluid and some in this case, very slight disturbances, alterations on RPE in the papillomacular region. Another case of central serous chororetinopathy with subretinal fluid with some deposits on the level of RPE, some alterations which were the witnesses of a rather long-lasting process, and a slight hyperfluorescent points in fluorescent angiography in the upper part of the macula. Here, another case of RPE alterations, which were very well visible in fluorescent angiography, and corresponding region was documented by OCT, showing the presence of subretinal fluid. Some other changes concerning RPE alterations, which were very well documented by OCT, show some degenerative spaces intraretinal and some subretinal fluid as well. Here is a case with a huge lack of RP cells in the central macular region and corresponding OCT, which we can see on the right side, shows that even in the distance of this RP alteration, still there are some subretinal fluid present. Here, a case of Arkin maculopathy with very typical shape of RPE atrophy and corresponding OCTB image showing typical case of RPE alterations located parafoveolary. In the central subfoveal region, there is normal RPE layer. Here, it's a case of diabetic retinopathy, non-proliferative, early stage with a lot of small retinal hemorrhages with no leakage and no DME presence on OCT. The second case of the diabetic retinopathy, the same stage, non-proliferative, no leakage. Some discrete ischemic areas are present. However, no, it is not very important in that patient, and no leakage in macula nor DME. Here, a case of diabetic retinopathy with moderate DME and very slight hyperfluorescence in the center, and as we can see on OCTB, the presence of so-called moderate DME. Some other cases with long-lasting edema with some retinal deposits very well visible in OCT-B. Here it's interesting case with showing the necessity of making the diagnosis based on these two methods, because on the left side we can see the hyperfluorescence in the region of multiple microaneurysms, but OCT-B shows us that besides the vascular edema, there is as well the presence of epiretinal membrane. It is important when we take decision about the type of treatment. Here is another case of a patient with diabetes. It's already a patient which was the retina was lasered because of the huge areas of no perfusion. But in fact, in the central area, some diffuse hyperfluorescence is present. But when we perform OCTB, there are mainly some degenerative cysts rather than active DME. A very important case with a huge DME on the right side, which corresponds to a very severe macular ischemic maculopathy, which is easily visible on the left side in the case of fluorescein angiography. And proliferative diabetic retinopathy, where we can see still some leakage from neovascularization, and on OCTB we can see the difference between the thickness of the retina corresponding to on the left side of the scan we can see very thin retina, which is the ischemical retina. On the right side, the retina of normal thickness. Besides, of course, such other vascular pathologies and as venous occlusion should be well diagnosed in the use of these two methods, because as we can see, we can observe some ischemic regions, some hyperfluorescence of fluorescein angiography, but in fact there is no big cystoid macular edema. There are some rather preretinal alterations in the form of epiretinal membrane. Macular telangiectatic changes are sometimes confused with AMD, so we have to take this attention. Here we can see how it looks in fluorescein angiography and image when we use complementary examination in the form of OCT-B. It is important as well to remember that in some cases of retinal telangiectasia, we should make more profound diagnostic looking for pathological neovascularization. And in this case, these two methods we mentioned today are used. retinoschisis, when we can see on OCT-B type typical retinoschisis, in this case in papillomacular region, which there is no leakage on fluorescein angiography, and often this is associated with some congenital abnormalities in the optic nerve head region. In conclusion, multimodal imaging should be a standard procedure for diagnosis of retinal diseases. The important role of fluorescein angiography in retinal vascular disorders should be remembered. Simultaneous fluorescein angiography and OCT imaging provides more accurate and fast diagnosis for several retinal pathologies. Thank you very much for your attention.
Esteemed colleagues, dear organizing committee, thank you for the opportunity to talk and present at this interesting conference. I have the privilege to be the head of Department of Ophthalmology at Poznań District Hospital in Poznań, as well as work at the Department of Ophthalmology at Military Institute of Medicine in Warsaw. In both of those places, I work with patients with ocular tumors. I treat patients with ocular tumors, and in both of those places we try to incorporate the latest innovations in ocular oncology. These are my disclosures, none of which are important or relevant to today's topic. Today I would like to address three main topics in the field of innovations in ocular oncology. First, we need a proper diagnostic methods, so a little bit about the advancements in imaging. Then obviously we treat our patients, so some latest revelations in the treatment of ocular tumors, and finally what's in the future or near future, so what's ahead of us in the field of research in ocular oncology. Wide-field fundus photography may not be the latest innovation in ophthalmology, but it has changed the landscape for the ocular oncology patients a lot, as first of all, it's a great screening tool allowing us for a fast and precise way to check if the patient has any fundus lesions. Then it allows for a great follow-up method, as we can compare pictures taken in different stages of the disease. Here we can see how easy it is to implement wide-field fundus photography to document the progress of shrinkage of uveal melanoma after brachytherapy. On the left, we can see a lesion before treatment, before brachytherapy, and on the right, we can see the effect after a couple of weeks after the treatment. Another tool that is probably not considered a new tool, new diagnostic method in ophthalmology as a whole, but it's quite a useful tool for specialists dealing with ocular oncology. I mean OCT angiography, so optical coherence tomography angiography. It's a non-invasive way to look for vessels in the retina and vessels in the choroid. Unfortunately, we have not been able to develop a pattern of the vessels in the choroid for uveal melanomas and for uveal nevi. However, OCT angiography has proven very useful to determine the source of subretinal fluid which presents in close proximity to melanocytic lesions in the fundus. For almost 30 years, we've known that the accumulation of subretinal fluid may be a risk factor for the transformation of uveal nevi into uveal melanomas. In 1995, Professor Shields presented a study that confirmed that subretinal fluid is a significant risk factor in this process. Before the wide use of OCT angiography, some of the lesions which presented with this subretinal fluid have been considered transforming into uveal melanoma. Now we have a very fast, very easy way to determine if uveal nevi present with choroidal neovascularization, a neovascular membrane that is not a sign of malignant transformation into choroidal melanoma. So I strongly suggest we try to implement this in our everyday in the everyday way we see our patients with uveal nevi. Another procedure that has been used before, but probably not in the field of ocular oncology, is dermoscopy. Dermoscopy is a non-invasive procedure widely used by dermatologists and oncologists to determine if a lesion that we're looking at is malignant or not by analyzing a series of patterns in the lesion. It may be implemented in ocular oncology to improve our diagnostic process, but also in pre-surgical planning to determine safe surgical margins of the lesions that we are planning to remove. Here we can see two pictures. On the left is a compound nevus seen in slit lamp photography, and on the right we can see the same compound nevus seen in dermoscopy. We can see the difference in the imaging method. We can see the difference in the pattern imaging and in the quality of the image. Now I would like to move on to treatment. We know that some of the intraocular lesions may be treated with radiation therapy. Not much has changed in this topic in the latest decades. Maybe it will change a little bit, and the latest innovations in chemotherapy. Starting with, for 20 years since the COMS study, we have known that brachytherapy, either with a iodine or ruthenium plaques, is an effective way of treating uveal melanoma or other intraocular tumors. Both iodine and ruthenium plaques are considered to be low dose rate brachytherapies, which require long irradiation times, sometimes even a couple of days. There has been reports of high dose rates brachytherapy using yttrium-90 brachytherapy that requires single surgery, and the irradiation time is counted in minutes. So that may be a significant change in the process of doing brachytherapy in the patients. Now this method is being studied in the United States. It hasn't been approved in Europe yet, but we are looking at it with high hopes. Radiation or brachytherapy may be also used to treat adnexal tumors, for example, a basal cell carcinoma of the eyelid. If there are contraindications for surgery, brachytherapy might be a way to go for some of our patients. If neither surgery or radiation therapy is viable for our patients, fortunately there have been a lot of developments in the field of immunology and immunotherapies, chemotherapies for our patients. There has been a lot of positive feedback with vismodegib or sonidegib in the treatment of basal cell carcinoma. There also has been reports of pembrolizumab and sempilimumab in the treatment of squamous cell carcinoma, as well as nivolumab in the treatment of melanomas. Here we can see one patient with an extremely massive basal cell carcinoma infiltrating not only the eyelids but also the orbit. It's definitely not a surgical case, and we can see that there's a great improvement after vismodegib in the treatment of this tumor. I would like to delve a little bit into what's in the near future in the field of research in ocular oncology. We are living in the era of emergence of artificial intelligence. We hear about new ways to implement AI in our everyday life. We talk about implementing it in medicine as well, obviously in ocular oncology as well. There have been a couple of papers regarding the prediction models to assess the risk of malignant transformation of choroidal nevi. There has also been some research done in the field of calculating the survival rate after the diagnosis has been made. Also, there have been studies to implement AI in the assessment of photographs, either of iris melanomas or of the uveal melanomas. A sort of a holy grail in the field of ocular oncology is a way to detect some kind of uveal melanoma biomarker in a non-invasive way. Usually we talk about a blood sample. For many years there have been many studies describing advances that's been made in this field. However, apparently we are not there yet. The latest study, this year's study, observed ctDNA levels in patients with uveal melanoma metastasis. However, the conclusions state that it does indeed need a lot of more research. Other fields of biopsy include aqueous and vitreous biopsies. Here we've been a little bit more successful, and there's been a lot of ongoing studies regarding aqueous or vitreous biopsies in the diagnostic process or follow-ups of retinoblastoma, uveal melanoma, or vitreoretinal lymphomas. To sum up, the latest innovations in ocular oncology are transforming the diagnosis, treatment, and management of eye cancer and eye tumors. Advanced imaging techniques, targeted treatments, exciting new research possibilities are improving the outcomes for our patients. The future of ocular oncology is bright, and we can look forward to even more groundbreaking advancements in the years to come. Thank you for listening. Thank you again for the opportunity to present at this conference. I will be available at the discussion to answer any questions should they arise. Thank you. Goodbye.
Good morning. Good evening. Okay, so I think that we can start the discussion. We can start by one by one. We don't have one speaker, but we can comment. Siluma. My experience with Siluma, I had a chance to try this device, and it is quite impressive. The quality is amazing, But the ergonomics, other aspect, wonderful, because if you've ever worked with stereo digital devices, then you know that we may have problem with ergonomics, with turning our heads. This is not the case here because of the C-arm, C-shaped arm. Maybe you can tell me if you think that when you buy such an expensive device, we should also have a backup, and the backup is traditional microscope. I think that any backup is useful, is necessary. At the moment, we don't have any feedback. It was a year and a half of testing it at the surgery wards, and no feedback was received. But in terms of optics, we may have problem with the bulb, with the buttons. Here, the device may make problems. That's something natural. It may happen to all equipment that we have in the surgical ward. But it's not our aim to look at its problems, or we cannot use it. I'm not talking that it will break down, but I also conduct strabismus surgery, and I need more visual field. Is it possible in Siluma, with the development, with the progression of screens, we will be able to have bigger field, because now we are limited by the monitors, by the screens that are used on face or in digital mode. But if we have a bigger monitor, a bigger screen, well, in 4K we would lose some resolution because of the number of pixels that we need to organize on the screen, but bigger visual field will be possible. Yes, for sure. So a lot of possibilities. Thank you very much for your response. There are two questions to me on chat, so I will try to answer them. The first question is about the number of photocoagulations that we can perform during one session. In multi-spot lasers, it has been described by Manchester Pascal study, the number of foci that we need to perform to have regression of neovascularization should depend on the severity of retinopathy. But if the question was about the number of foci, then our one limitation or is resistance of the patient, and I regularly perform photocoagulation with multi-spot laser with 2,500 foci, and when we look at the first DMS studies, ATDRS studies, this is a very good beginning. Then we can make it more dense, but we need to look that maybe this density should be higher in multi-spot than in traditional lasers. So I would say 0.75 or 0.5 distance. And the second question, are there any studies on the use of subthreshold micropulse laser to prevent geographic atrophy? Yes, there are good quality studies, but they are sparse, and they are conducted by Jeffrey in clinical ophthalmology. There was a study, and he compared the group of patients that underwent laser therapy with geographic atrophy and the control group, and the progression was I don't know, during 3 years was lower twice. So there are such studies, but we don't have a lot of them, and we treated them as a very good and very confirming research. We don't have Professor Świech about multimodal imaging. She had a presentation. Wojtek Adamski also showed it in the diagnostics of tumors, and you can confirm that multimodal imaging is very essential. It's essential. So I have a question to you. angio-OCT and FA in oncology. Can you tell us more about it? Generally speaking, we all know that OCT angiography, angio-OCT, has marked its position and it affected and it changed the indications for these OCT. But of course, there are some niches where angio-OCT still cannot include all of these indications. For example, we have the vascular problems of choroids, and angio-OCT doesn't give us good results like FA. As I mentioned, when we have the fluid, subretinal fluid, angio-OCT in many cases gives us response to the question if this is a fluid due to the transformation of the lesion or because we have a neovascular membrane. But here we have to take into account technological restrictions. Many devices allow us to have good imaging of the posterior part, but if the lesion is located peripherally, then this division of different layers in devices is lost. Of course, it all depends on the equipment, on the device. We have still having advances in this aspect. Angio-OCT, broad spectrum angio-OCT will be the future, but this is not the standard now. So angio-OCT, unless in some aspect, will be in the future still valid. Yes, I agree with your opinion. And I think that angio-OCT is a breakthrough in diagnostics of rarer diseases. It gave us a lot in terms of imaging neovascular membrane, in terms of its potential for proliferation. But in choroidal diseases, we still know that the pace of the flow is important, so we don't see all microaneurysm, especially if we have perfusion in the periphery, then we probably need broad angiography. And one question from chat about the use of OCT, anterior OCT, in the diagnostics of eyelid changes. Yes, this question is if there are any experiences, if I have any experiences in OCT and eyelid problems. I don't have such experience because this OCT technology that we use in also proliferative changes in the eye, but in the eye structure only, requires transfluency. So if we, for example, have the pigmentation lesion, or if the sclera is a still problem for OCT, then we are not able to detect such lesions, such changes. And OCT is now starting to be present in dermatology. So ophthalmology was first. Sometimes we are the last, but here we were first, and we first use OCT. And now dermatologists start to use OCT for skin lesions, but this is different wavelength. This is the difference about the wavelength. So I've never used such devices for skin lesions of the eyelid. They're totally different devices. They use different wavelengths. So in terms of our OCTs that we use, because they usually have 1,000 nanometers, we won't be able to diagnose skin. Dermatological OCT is over 1,300 nanometers. So, of course, maybe we will have one universal device in the future, or maybe maybe we have to invent our own OCT with other wavelength. If not, we have to use devices used in dermatology, not in ophthalmology. I have one more question, because it's quite impressive, the number of therapies in tumors, in cancers. We know that this is a problem because I don't think that ophthalmologists frequently see such cases. There are some organizational schemes in different countries. You said at the beginning that you work in 2 centers at the same time. Do you think that the patients should be put in one center, or maybe we should contract such procedures in each region in Poland, or maybe we should accumulate them in specified centers to provide better quality of diagnostics and treatment? I think it depends on the aspect of oncology, because we have a broad spectrum of lesions in ophthalmology. We have many lesions on eyelids due to the chronic UV irradiation. We have changes of the conjunctiva, we have changes in the eyeball, and we have changes that are located everywhere in the eye. So it's their frequency and the approach is different. The approach depends on the frequency, so we cannot put everything to one bag. But what we should focus on, especially when we train younger doctors, is that they need to know the most frequent lesions, skin, eyelid skin, well, eyelid only, blepharitis maybe is mentioned, or the entropion is discussed during the lecture. If you don't work in a specialized center, or if you don't put your own work, then the diagnostics of skin lesions may be not perfect. I want to say that there are many lesions of eyelids, and good diagnostics should be important, and I think that all ophthalmologists should be able to do it. So I don't think we should centralize it. We should all be able to diagnose such lesions and operate them with the proper margin and so on and so forth. In terms of the frequent lesions, I think that intra-eyeball lesions is also very important. We have many different problems. This should be something that is at school. It should be basic. We don't want to stress the patients. For example, we see the dark lesion that may be nevi or not necessarily, and we, say that maybe this is melanoma. You should now go to Krakow, to the other city, to check that. No, our diagnostics should be better. We should do it on our own. We shouldn't refer patients to specialized centers. Melanomas in the eyeball are rare, 200 cases per year. So, sometimes in such cases, we have to refer patients. We have to have at least one center in the region. But in terms of treatment, but in terms of diagnostics, we should be able to do it, and we should only refer cases that we have already diagnosed. We should trust our own possibilities, and we should trust our capabilities of diagnosing such lesions. Thank you very much. We have still 3 minutes, and I have a question to the person, to Łukasz Mach, about the microscope in the treatment. Have you ever had experience in using this microscope in oncological diseases? Because you've presented anterior chamber surgery, but can you tell us about oncological treatment? Well, during my presentation of this device, and my experience, well, I have to say that I've never had any oncological lesions. But digital microscope gives us a lot of options. So the more system will be used in centers, clinical healthcare centers, then more feedback we will get from surgeons, and thanks to that we will be able to develop new systems, new applications of Siluma, or new parts of Siluma to make such procedures possible. So all advancements of this platform for visualization will be about the cooperation of surgeons, because not always engineers that invent something translates later into the clinical practice of the surgeon. So it's good to have the information, what would be useful, what kind of camera or what part of the device would be necessary. So we don't want to develop something that won't be used in clinical practice. Yes, I confirm. For me, this ergonomics was amazing. It's something unique. It was wonderful, but the price will be always analyzed. So do you have a lot of Siluma devices around the world? I'm not talking about Poland, because I know that this microscope is present in other countries, not in Poland. 9, as far as I know, 9 are active: France, Italy, Poland, Australia. 1 microscope is now in Poland. So we gather information about it. We send more and more devices now to Europe for presentations. And recently, what I've learned, and from my own experience, I see that engineers work hard to develop this microscope, and they launched another software to that strengthen the contrast, to visualize some structures, tiny structures. And this digitally processed image can distinguish the image. And this distinction wouldn't be possible on a traditional screen. So engineers are keeping up with the suggestions of the surgeons, and they are doing such advancements for them. Thank you very much for preparing these presentations, and thank you all that you were present. Let's see each other in a year. Thank you.
Good afternoon. My name is Ewa Kosiar-Jarecka. I work at the Department of Diagnostics and Microsurgery of Glaucoma at Medical University of Lublin, Poland. And in the next few minutes, I would like to talk about innovations in medical treatment of glaucoma. Glaucoma is the leading cause of irreversible vision loss worldwide, characterized by elevated intraocular pressure and progressive optic nerve damage and visual field defects. While its pathogenesis is not well understood, intraocular pressure is the only modifiable risk factor identified to prevent glaucomatosis vision loss. Target IOP is the level of IOP preventing from glaucoma progression and may be obtained by topical treatment, laser, or surgical procedures. Traditionally, medical management, especially installation of hypotensive drops, remains the first line of treatment in most cases of adult glaucomas. There are few groups of anti-glaucoma medications on the market, all of them decreasing IOP, some by suppressing the production of aqueous humor and some by increasing aqueous humor outflow. The last breakthrough, which changed glaucoma management, took place in 1996 with the introduction of prostaglandin analogs, which have soon after become the first line of medical treatment. And some groups of medications are present on the market, and someone may ask whether it is enough, whether current medical therapy is successful. And the answer is yes. It is widely proven that most of anti-glaucoma drops decreases IOP by 20–30% in monotherapy, which enables to obtain target pressure, slow glaucoma progression, and stabilize the disease. But on the other hand, the answer for this question may also be no. Low target pressure in advanced glaucoma usually cannot be obtained successfully by polytherapy. Moreover, prolonged application of anti-glaucoma drops causes unacceptable side effects. Additionally, despite medical and surgical therapy, some patients progress to blindness. The solution for this problem is the consistent search for new groups of anti-glaucoma agents. Medical therapy poses a unique set of challenge in the long-term care of anti-glaucoma patients. Patients must buy the medicine, successfully install the drop into the eye, use the medication consistently, and dose at appropriate time. So the patients do not apply the drop. On average, patients take 30–70% of prescribed doses, and on average, half of them discontinue medication in the first months of therapy. Poor adherence and persistence is associated, of course, with the increased risk of progression and finally blindness. The solution for this problem is the consistent search for the strategies improving adherence and persistence. IOP is the only glaucoma risk factor which modification indirectly protects retinal ganglion cells. However, alone IOP is not sufficient to cause or stop glaucoma. There are patients with long-lasting ocular hypertension and normal tension glaucoma, ones who develop progressive glaucoma in normal range of IOP. Direct neuroprotection is the one which targets retinal ganglion cells directly. And to address this neurodegeneration directly, numerous preclinical studies seek to develop protective therapies that act independently on IOP. So there are three main problems which are targeted by innovations in medical therapy of glaucoma. First solution is the introduction of the new groups of anti-glaucoma medications. And first group of new anti-glaucoma drugs are ROCK kinase inhibitors with ripasudil and netarsudil commercially available. The mechanism of action of ROCK inhibitors suggests that they may be a marvelous drugs in glaucoma therapy. First, ROCK inhibitors increase aqueous humor outflow and decrease outflow resistance in trabecular meshwork. Additionally, netarsudil is a norepinephrine transporter inhibitor, thanks to which causes reduction in aqueous humor production and decrease in episcleral venous pressure. Last two properties in the list are even more interesting. In preclinical studies, ROCK inhibitors showed different neuroprotective capacities. Moreover, they decrease wound healing processes after trabeculectomy, causing an improvement in the outcome. ROCK inhibitors reduce IOP by 20–25% in patients with primary open-angle glaucoma. The next drop is latanoprestenon bunot, which is a nitric oxide donating prostaglandin analog and was approved for the reduction of IOP in patients with open-angle glaucoma. LBN combines the IOP lowering effect of prostaglandin analogs by increasing the uveous scleral outflow, while nitric oxide relaxes the trabecular meshwork and improves the trabecular outflow. LBN decreases IOP by 25-35%. Some clinical trials with beautiful names, some of them taken from the ancient Greek mythology, checked its efficacy and safety. In Apollo trial, for example, in which once daily LBN was compared to twice daily timolol, significantly greater IOP reduction was observed for LBN. Overall, the adverse effects profile of LBN was similar to that one of latanoprost. There are also some interesting new groups of anti-glaucoma medication on investigation. Adenosine is a nucleoside which increases the conventional outflow facility. Phase 2 trial for trabodenosone, a selective A1 agonist, showed significant IOP reduction with no serious adverse effects. And omidenepac isopropyl, OMDI or Omlontai, is a non-prostaglandin selective prostanoid EP2 receptor agonist and is known to decrease IOP by increasing the conventional and uveoscleral outflow. It was approved in Japan and by FDA in 2022. And in phase 3 trial, OMDI was determined non-inferior to latanoprost. OMDI was well tolerated, and a related study found OMDI to be a potential pharmacological alternative for patients unresponsive for latanoprost. The second goal to be addressed in medical treatment of glaucoma is to improve the adherence and persistence, and there are some ways to achieve this. The idea of releasing patients from drop regimen is not new. OcuCert was the first sustained pilocarpine implant introduced in 1975, but the product was soon taken off from the market because of poor medication tolerability. Since then, different ideas of the drug delivery systems are tested with extraocular and intraocular implementation. Some of them has finally been released to the market. First, bimatoprost ocular insert, bimatoprost ocular ring first, which is a silicone and polypropylene ring impregnated with bimatoprost, available in different sites, designed for insertion between fornices. It continuously elutes bimatoprost for 6 months, after which it needs to be replaced. IOP control over 6 months was found to be less than predicted with topical drop, with the main adverse effect being mucinous discharge from the eye. Phase 3 trial are awaited, and the study to evaluate efficacy and safety with the fixed combination insert composed of bimatoprost and timolol are currently underway. The travoprost punctum plug is composed of travoprost encapsulated in microparticles suspended within a polyethylene glycol resorbable hydrogel rod. Upon exposure to the tear film, the rod swells to occupy the space within the lower or upper canaliculus. Hydrolysis of the microparticles takes place over 90 days, resulting in a sustained release of travoprost into tear film. You see that the implant has fluorescein to aid its visualization. Clinical results with the device were reported after a phase 2 clinical trial in comparison to timolol, and in this trial at 90 days, clinically meaningful IOP reduction was observed for both groups. The device retention rate were noted to be about 48% and 90 days. There is also a lot of different possibilities and studies evaluating external ways of drug delivery, most of them at preclinical or phase 1 or phase 2 of clinical. For intraocular implants, Durysta was approved in 2020 as a biodegradable implant for injection into anterior chamber via prefilled injector. It delivers 10 micrograms of bimatoprost to provide an IOP lowering effect lasting for 4 to 6 months. Clinical trial Artemis showed that Durysta was non-inferior to timolol. Additionally, there were no adverse events typical for prostaglandin analogs. The main concern was the drop in corneal endothelial cells density, and ongoing trials are now evaluating new regimens of administration to prevent significant corneal endothelial cell loss. Another sustained release implant, iDose, is now FDA approved and is very interesting in construction. iDose includes a reservoir housed in a titanium implant that is inserted in the anterior chamber and anchored with the trabecular meshwork. This implant is enclosed with the titanium membrane that regulates the release of travoprost into the anterior chamber over 1 year. When the device is depleted of the drug, the reservoir of the implant may be removed and replaced. The slow-releasing drug delivery systems may also be implanted under the conjunctiva. The example is Duracell, biodegradable implant that is approximately the size of the rice grain. The implant can be inserted in the subconjunctival space using 25 gauge needle and releases latanoprost up to 1 year. Recently, there have been some advances also in the field of electronic medication monitoring, including CaliDrop and the VersDrop device. The CaliDrop, so this is the one, is the relatively small and fits most standard size eye drop bottles. Pressure sensors here are on the size of the device and determine if enough force was applied to dispense a drop, and the positional sensor on the base confirms that the bottle was inverted during the drop administration. The second one, the VersDrop device, tracks eye drop usage by registration when the eye drop cap bottle was removed and replaced. The external modalities include latanoprost microdose delivery with Optejet. The Optejet dispenses the appropriate dose of latanoprost in a gentle spray that coats the surface of the eye, all in vertical position with straight head, and all without the frustration associated with the traditional eye drops. A clinical study with glaucoma patients showed that 95% of subjects attempt self-administering using the Optejet very successful. Fixed combination ophthalmic solution can be advantageous in majority of glaucoma patients who require multiple medications. The innovation in fixed combination drugs is now first release of triple fixed combination with bimatoprost, brimonidine, and timolol. Additionally, there is a variant need for fixed combination without beta blocker. One of the latest is FCNL with the first fixed combination of a prostaglandin analog latanoprost and the ROCK inhibitor netarsudil. Moreover, the preservative-free fixed combinations are now available. The problem with the adherence and persistence is related to the glaucoma patients, so maybe the right solution for this problem is to elaborate adherence-free and patients-free therapeutic strategies. And this idea evolves as the paradigm of interventional glaucoma, where effective and safe laser and surgical procedures are offered to the patients early in. And finally, direct neuroprotection is the holy grail of glaucoma care. Neurotrophic factors play a key role in cell survival, but you have them listed here on the slide, but the most promising one is the CNTF, which has a neuroprotective potential checked in various types of glaucoma. The NT501 implant is a polymer membrane capsule containing immortalized human retinal pigment cells that secrete consistently CNTF, and the membrane capsule is semi-permeable, allowing consistent CNTF secretion. In glaucoma, following the safety trial, phase 2 clinical trials are currently ongoing to evaluate the efficacy of this implant in glaucoma, with expected completion this year. There are two methods of retinal ganglion cell repopulation by cells coming from stem cells: transplantation and endogenous transdifferentiation. However, this very promising solution for advanced glaucoma patients with attempts to restore vision has not yet been clinically. Dietary supplementation with a possible neuroprotective strategy tests a lot of different substances with the different mechanism of action and different relation to glaucoma pathogenesis. On the slide, you see some old friends, but two of them respect the special attention as there are coming new proofs for the neuroprotective action. First is the acetylcholine, which is involved in the synthesis of membrane phospholipids. Two interesting clinical studies are currently underway to further investigate the potential neuroprotective effect of acetylcholine in patients with open-angle glaucoma. First one is the RCT examining the impact of oral acetylcholine over a period of 1 year and is estimated to be completed this year. To further confirm the potential use of acetylcholine eye drops as a neuroprotective treatment, a large phase 3 RCT is planned to recruit 1,000 patients with open-angle glaucoma. The study is ongoing and has some centers recruiting in Poland. And the second most hot glaucoma supplement is nowadays nicotinamide. The critical role of mitochondrial dysfunction in glaucomatosis neurodegeneration presents a therapeutic opportunity for antioxidants, including nicotinamide. Human clinical trials started evaluating nicotinamide oral supplementation in high doses in glaucoma patients, showing improvement in visual function. The glaucoma nicotinamide trial will evaluate oral nicotinamide neuroprotective effect in patients with open-angle glaucoma. This study started in 2022 and is planned to end in 2026. To conclude, new drugs has been introduced to glaucoma medical therapy. The new delivery system with sustained release are now available. And the results of randomized clinical trials regarding direct neuroprotection are going to come soon. Thank you for your attention.
Good morning, I am Izabela Karska-Basta. I would like to thank you for this interesting conference. My today's presentation is about biosimilar drugs targeting vascular endothelial growth factor used in ophthalmology. That is a fast-growing group of biological drugs, commonly known as anti-VEGF preparations. I will start by giving you an overview of the drugs I'm going to discuss. Biological drugs, according to the EMA, are medicinal products that contain one or more active substances produced by a living organism or derived from a living organism. And they are, for example, monoclonal antibodies or fusion proteins. These are large molecules produced by bacteria, yeast, animal cells. It is the fastest growing class of drugs in the United States and one of the most effective, but also the most expensive drugs available in the world. Biosimilar drugs, according to EMA, are biological drugs that are very similar to another but already approved biological drug, so-called reference drug. Biosimilars are approved according to the same standards of pharmaceutical quality, of safety and efficacy that apply to all biologics. At this point, it's important to note the difference between biosimilars and so-called generic drugs. It is important to say about the manufacturing. It's mainly related to the complexity of the process and hence the high price of biosimilars or biologics compared to much lower cost of production of generic drugs. What is also important is the difference in the degree of difficulty of identifying it with respect to the structure and the function of biosimilars and generic drugs. You will find all these differences in the table. Anti-VEGFs. intravitreal injection of these drugs affect blood vessel permeability, angiogenesis, or inflammatory responses by inhibiting VEGF signaling. In fact, in recent years, they've been a standard treatment in patients suffering from various types of conditions like AMD, wet AMD, or macular edema in the course of retinal vein obstruction or occlusion, or macular neovascularization in the course of myopia, or in diabetic macular edema. We usually use 5 biologics in intravitreal injections. Here you can see the main actors on this ophthalmic stage. I correlated the names of the drugs with well-known actors. And the first one is ranibizumab, a fragment of recombinant humanized monoclonal antibody. Brolucizumab, a single-chain fragment of monoclonal antibody. Bevacizumab, recombinant humanized full monoclonal antibody. Aflibercept, a recombinant fusion protein consisting of fragments of extracellular domains, human VEGF receptors, and the Fc fragment of human immunoglobulin. And the newest and the youngest, faricimab, humanized biospecific full antibody that works by inhibiting 2 pathways, not only anti-VEGF but also angiopoietin 2. Only some preparations containing the biological molecules are called reference drugs. And here you can see them in the table 1. A reference drug in clinical trial is ranibizumab or aflibercept. On the other hand, the career of bevacizumab is different. This drug was registered for oncological indications, but it has been widely used in ophthalmology. Outside of these indications, since 2005, in March 2024, EMA issued a positive opinion for the use of bevacizumab gamma for ophthalmic indications, and here only in wet AMD. 1 year before, in 2023, FDA rejected the application to register the drug in the US for this indication. In the United States and in the EU, biosimilarity of new drugs, so biosimilar drugs to the reference drug, is demonstrated with the step-by-step approach, which differs from the approval pathway for new original biologics. And this can be visible here on the right. In the biosimilar pathway, we more emphasize analytical data than clinical trials, which are important in launching new original drug on the market. This is on the left side. Analytical and functional studies should be conducted to determine the similarity of the physical and chemical properties of the drugs. Preclinical studies can be also conducted to assess toxicity. Clinical pharmacologists that assess pharmacokinetic similarity are the main factor that determines biosimilarity, although we can also use pharmacodynamic or pharmacometric analysis. It is important to demonstrate the safety of the candidate for biosimilar drug. It must be similar to the reference product. Immunogenicity should be evaluated when we know that the reference product presents immune toxicity, or this may compromise patient safety. The efficacy of biosimilars is assessed by determining whether the selected clinical endpoints are within the established margin of equivalence. Before approving a biosimilar drug, regulators evaluate everything and they gather analytical data, preclinical, pharmacokinetic evidence, as well as evidence regarding drug safety and efficacy. What about approving biosimilars for use? In the US, the guidelines say that the biosimilar drug must demonstrate, as I said before, similarity to the reference drug in terms of qualitative features, biological activity, safety, efficacy, based on comprehensive comparative studies. In the United States, however, FDA requires evidence that there are no clinically significant differences in terms of purity, safety, and strength between the biosimilar and the reference drug. What is interesting, if no clinically significant differences are found, the biosimilar drug can be approved for all indications of the reference biologic drug, even if that biosimilar drug hasn't been directly tested in comparative clinical trials for other broader indications. This rule is called extrapolation of indication. In this way, we reduce the need to duplicate clinical trials and it lowers the costs of development of biosimilars. In terms of names, this name's nomenclature differs in the EU and in the United States. In the EU, it's a unique trade name combined with international non-proprietary name. In the US, this is the main name of the drug plus random distinctive four-letter suffix, lowercase, connected with the hyphen. The rapid development of ophthalmic anti-VEGF biosimilars, is evidenced by the large number of formulations approved in recent years and documented current trials and approval of this drug in many countries. The first biosimilar drug approved in ophthalmic indications was Razumab by Intas Pharmaceuticals. So biosimilar ranibizumab approved in India in 2015. In this table, you see biosimilars of aflibercept and the status of their implementation. You can see that there are many of them. And this table shows biosimilars of ranibizumab and their implementation status. And here we have biosimilars of bevacizumab and their approval status. Interestingly, in Russia or Argentina, two of these drugs have already been approved some time ago, because in 2015 and 2016. There are many hopes associated with biosimilars because they have a lot of advantages. This is faster, easier approval pathway compared to reference drugs. We have also increased competition between manufacturers of drugs. It will positively affect lowering the costs for patients and healthcare, and it will increase availability of these drugs to a wider range of patients. The obligation to monitor post-approval effects of these drugs increases their safety, and this is important because we have lesser emphasis placed on clinical trials prior to approval of a biosimilar compared to new original biologics. Unfortunately, biosimilars have disadvantages. They raise concerns, and not all hopes that we place in them can be fulfilled. The first analysis of their impact on both in European Union and United States showed that they show less reduction in drug costs for patients than expected. Surveys conducted among ophthalmologists in Europe and US indicate physicians' concerns about the safety of biosimilar, their efficacy, immunogenicity, and their efficacy for extrapolated indications. Similar concerns are also about patients. For example, there may be some differences from reference drugs, and there is a problem with the difference between formulations within different batches of the one drug. The lack of this same situation, well, this is because it may impact the properties of the biological molecule. We need to monitor side effects of new biosimilars after they have been approved. Well, it can be to be an advantage. But on the other hand, it can raise concerns among patients that are still taking the drug that is monitored. To sum up, biologic drug therapies are very costly, and biosimilars give us a hope that these increased will be more available for patients thanks to reducing costs and while maintaining their safety and efficacy. Unfortunately, analysis of costs indicate a significant importance of regulations, the attitude of pharmaceutical companies and insurance companies, politicians, regulators on the final price of the therapy and any savings that may come out of it. Biosimilars raise some concerns among doctors and patients, so we should popularize knowledge about them. Further comparative studies of reference drugs and biosimilars are necessary. And this is the list of the literature I used when I was preparing my presentation. Thank you very much for your attention, and I wish you a pleasant conference.
Ladies and gentlemen, dear colleagues, I have the pleasure of presenting the innovative properties of ozonated plant oil in nanosomes. This is the lecture by invitation of the InView company. Here you have the potential sources of conflict of interest. Let me start. Why is it worth using antiseptics? Unfortunately, the presentation is moving. The slides are changing quite slowly, so I guess that's a slight technical problem. Hopefully, we will be able to overcome it soon.
Niestety prezentacja została zablokowana chwilowo. Muszę spróbować jeszcze raz.
Unfortunately, the presentation seems to be frozen, so I'll turn it off and on again. The disadvantage of being live with you, ladies and gentlemen.
Niestety prezentacja się nie uruchamia.
Unfortunately, the presentation doesn't start. So, I suggest that we move on to the next presentation. In the meantime, we will solve the technical problem. A remark to the technical department. Szanowne prezydium, koleżanki i koledzy, na wstępie chciałbym podziękować organizatorom tej ciekawej konferencji za zaproszenie mnie do wygłoszenia prezentacji. Innowacje w obliczeniach soczowych wewnątrzgałkowych są tematem mojego wykładu.
Oto moje ujawnienia finansowe. Paul Gauguin, francuski postimpresjonista w swoim słynnym obrazie znajdującym się w Muzeum Sztuki.
Three fundamental questions. Where do we come from? What are we? And where are we going? Thinking like Gauguin, let's try to refer these questions to intraocular lens calculation. Where do we come from, or a brief history of intraocular lens calculation, which begins with intraocular lens implantation. Sir Nicholas Harold Lloyd Ridley was the first person to successfully implant an intraocular lens on November 29, 1949 at St. Thomas Hospital in London. However, the patient obtained a refractive error of -18 diopters sphere and -6 diopters cylinder. Thus, there was a need to improve the accuracy of intraocular lens calculation, especially after the invention of phacoemulsification. The first intraocular lens power calculation formula was developed by Sviatosław Nikolaevich Fyodorov in 1967. Since then, many intraocular lens power calculation formulas were launched. The first classification considered the subsequent generations. Thus, where are we? Despite of such many intraocular lens power calculation formulas, still only 73.7% of patients achieve prediction error after phacoemulsification within ±0.5 diopter. Data according to European Register of Quality Outcomes for Cataract and Refractive Surgery. And where are we going? We try to improve accuracy of intraocular lens calculation, especially in difficult cases such as short and long eyes, vitrectomized and pediatric eyes, or eyes after corneal refractive surgery. So, if our goal is to improve the accuracy of intraocular lens power calculations, let's try to analyze what innovations in this area have been introduced recently. I distinguish three categories of these innovations, such as new intraocular lens power calculation formulas, new their classification, and new tools to evaluate their accuracy. Here is a very useful classification of intraocular lens formulas proposed by Koch in 2017. He emphasized logical approach instead of generations. Formulas that have been developed recently are based on artificial intelligence, and these can range from methods that use AI alone, such as Carmona or Nalasami, to optical formulas that utilize AI components to refine their accuracy, such as Hofer QST or 3C calculator. And now a few words about these latest formulas. The Carmona formula has been designed by David Carmona Gonzalez as a result of pure AI without optic components. It is based on two combined models of machine learning, such as regularized Bayesian neural network and Kubi's decision tree. Formula uses such input parameters: axial length, anterior chamber depth, corneal anterior surface central radius, width to width, and some optional. The main purpose is to improve the exactness in extreme and atypical eyes. The Hofer QST formula was developed in 2021 by Kenneth Hofer, Giacomo Savini, and Leonardo Taroni as refining third generation Hofer Q by using artificial intelligence. They aimed to increase accuracy in long eyes. Input data include axial length, keratometry, anterior chamber depth, and gender. The Nalasami formula has been launched by Ting-Yang Li, Joshua Stein, and Nambi Nalasami in 2022. They utilized ensemble machine learning model, which was consisted of two layers. The second layer consists of the meta model, which output is the final predicted refraction. The formula uses 5 compulsory variables axial length, keratometry, anterior chamber depth, wide-to-wide lens thickness, and one optional CCT. The Zulu formula has been published by Guo, Lu, Zhu, and others in 2023. They constructed two sets of learning features, and then two supervised machine learning models were trained, with each of two sets obtaining 4 submodels, each of which could function independently for intraocular lens power calculation in highly myopic eyes. Input data: axial length, keratometry, anterior chamber depth, lens thickness, wide-to-wide, and gender. Kenny and others, Koch, Wang, Hill, have published the Zeiss AI formula based on study with short eyes in July 2023. The formula uses following variables: axial length, anterior chamber depth, lens thickness, age, and gender. Unfortunately, the formula is available only in the United States. The 3C calculator is an upgraded Camelin-Calozzi formula, which originally only calculated intraocular lens power in eyes after corneal refractive surgery, and now, after the introduction of AI components, may also count intraocular lens power in virgin and pseudophakic eyes. It is recommended rather for long eyes. It needs mandatory inputs such as axial length, keratometry, flat and steep, anterior chamber depth, and optional such as lens thickness. The new classification of formulas is another category of innovations in intraocular lens calculation. In February of this year, Nagranie proposed a new division in which he significantly expanded the segment of AI-based formulas. He divided hybrid formulas into those that use AI to improve the thin lens versions, such as Lada's super formula, Kane, Hofer QST, or 3C calculator, thick lens versions like Pearl DGS, or paraxial ray tracing formulas such as Zeiss AI. Since we have so many formulas, this raises the question of which is the best, which is the most accurate, which is the most universal. There are many tools for assessing the accuracy of formulas. So far, mean absolute error, percentage of patients with prediction error within ±0.5 diopter, and median absolute error are the most commonly used. We can also utilize mean prediction error, where prediction error is a result of subtraction between measured postoperative spherical equivalent of refraction and preoperatively predicted spherical equivalent. Range of prediction error, standard deviation of prediction error, maximum prediction error, percentage of patients within ±0.25, ±0.75, and ±1.0 diopter are used less often. We can also use the combination of these tools, such as mean rank score developed by David Cook, which considers 6 parameters, and Haig's performance formula index, which considers 4 attributes. The mean absolute error, is the most frequently used, is a linear score, which means that all individual differences are weighted equally in the average. However, it is well known that in intraocular lens calculation, large errors are particularly undesirable. We don't need refraction surprises after phacoemulsification. And that is why Halliday suggested root mean square error for assessing the accuracy of intraocular lens formulas. How is the root mean square error calculated? First, the prediction errors are squared and averaged over the sample, and then the square root of average is taken. Since the prediction errors are squared before they are averaged, the root mean square error gives a relatively high weight to large errors. The root mean square error will always be larger or equal to the mean absolute error. The greater difference between them, the greater the variance in the individual errors in the sample. Of course, they are both negatively oriented scores, what means that lower values are better. Accurate intraocular lens power calculation is a very important aspect of phacoemulsification because patients' expectations for perfect vision after cataract surgery are still increasing. The exactness of intraocular lens power calculation formulas, especially for eyes shorter than 22 millimeters or longer than 25 millimeters, is still questionable, and there is no agreement among cataract surgeons regarding the choice of the formula. Many original studies have been published on this topic. I'd like to present a short review with methodology follows the PRISMA guidelines. The studies with the maximum sample, the largest number of compared formulas, and the most recent ones were selected. Accuracy of formulas was considered in terms of mean absolute error and percentage of patients with prediction error within plus minus 0.5 diopter. Root mean square error started to be used in studies only since 2023. Based on Cook's ranking, each formula was assigned an appropriate place in two above-mentioned classifications. The Kane formula obtained the highest number of first places. The second highest place was most often achieved by Hill-RBF 3.0, which was updated at the end of 2020 based on over 30,000 eyes. Detailed outcomes of this review have been recently published in JCM. As conclusions, IOL power calculation still needs improvement. Latest many IOL power calculation formulas, usually AI-based, have been developed. Such a large number of new formulas led to development of various their classifications. New tools for evaluating the accuracy of formulas contribute to progress in intraocular lens calculation. Kane seems to be still the most accurate AI-based formula. The newest formulas, such as Carmona, Hofer QST, Nalasami, Zulu, Zeiss AI, need further examinations. Since there is still no gold standard in intraocular lens calculations, so each case should be considered individually. And refraction surprises in IOL calculation occur even when we do our best. Although Winston Churchill, Prime Minister of the United Kingdom and Nobel Prize winner in literature, encouraging people to work more effectively, used to say, "It is not enough that we do our best. Sometimes we must do what is required." Thank you for your attention.
Okay, and now we're coming back to my presentation. So, innovative properties of ozonated plant oil in nanosomes. Again, this is my potential conflict of interest, and now what I left with. So why is it good to use antiseptics? Well, there are dark sides of antibiotics. Of course, even though antibiotics save lives and led to a great advance in medicine in the second half of the 20th century, we also know that overusing antibiotics leads to antibiotic resistance. In our ophthalmologic practice, it can lead to dry eye or hampering reparatory processes. It can stop it can distort the microbiome of the eye surface, and it can be an immunosuppressor. We also know that antibiotic resistance and drug resistance in general, according to the data, as of today, 700,000 people die a year. So 2,000, on average, 2,000 people a day die because they are infected by drug-resistant bacteria that can't be treated properly. And the simulations show that by 2050, the number will grow to 10 million. That would mean 27,500 people dying every day. So it's a problem we need to treat seriously. Antibiotic resistance has a long history, And depending on different antibiotics introduced in different moments, penicillin as the first antibiotic, then antibiotic resistance started forming very quickly, as you can see throughout the second half of the 20th century in relation to other different antibiotics. Antibiotic resistance started. So in 1996 happened the phenomenon. Alexander Fleming that discovered penicillin, and he was awarded a Nobel Prize in 1945. He warned about the dangers for incorrect use of antibiotics, and in his lecture said it's not difficult to create bacteria resistance to penicillin. Exposing them to concentrations not enough to kill them. The same happens in the body of a person. In terms of antibiotic resistance data for the eye surface of bacteria on the eye surface or in the inside the eye, we have very good data from Armor study from the US, published every couple of years. Here we can see data from 2015 showing that the antibiotic resistance is prevalent with different bacteria. Staphylococcus aureus, 36%, and CONS, 31%, are the most common, most resisted. In the last 70 years, 25 classes of antibiotics were created. However, new discoveries, we are missing new discoveries starting from 1987. And there are new pathogens resistant to many antibiotics. For example, Enterobacteriaceae, resistant to carbapenems, or gram-negative antibiotic-resistant bacteria. To give you an example, 1948, 38% of Staphylococcus aureus were resistant to penicillin. In 2012, 90% of bacteria in the UK and almost 100% in the US is resistant to penicillin, and almost 50% is resistant to methicillin. Also, the resistance against other substances is growing. For example, fluoroquinolones of second and third generation. It's been growing for years. Also, resistance against fluoroquinolones of third and fourth generation. What are the other side effects of antibiotic therapy? Well, the distortion of microbiome of the eye surface, hampering of the respiratory processes, immunosuppression that can lengthen the disease. And then why ozone? Why this solution I'm going to mention is so innovative? Ozone is the strongest oxidant that is currently existing in nature. We can see the oxidizing potential of ozone compared to other substances. The bottom iodine that is commonly used in ophthalmology, of course, as antiseptics in general. So antiseptic particle with ozone contains a broad spectrum of antibacterial action. There is no documented resistance of bacteria or evidence to induce resistance. It's perfectly tolerated on the eye surface and the skin around the eyes. And thanks to that, it can be a new valuable option in supporting treatment and prevention of eye infection. So here you can see the properties of ozone that can be useful for us, ophthalmologists. Apart from what I said, inducing regeneration of tissue, it's not toxic towards epithelial cells, which happens in iodine, povidone. Development of resistance seems to be impossible, which is very important. No allergies or hypersensitivity to the solution because there are no allergens there, and ozone is converted to particle oxygen, so it's completely safe, in other words. Here you see the antiseptic action of ozonated oil, first through direct oxidation, so slowly released O3 and its derivatives cause creation H2OR2 that are able to destroy certain pathogens, and then through interaction with macromolecules, with nucleic acids, cellular membrane and viruses and bacteria membranes, that leads to also a lot of beneficial effects. In the table you can see the high activity of ozonated oil towards numerous different forms of microorganisms, gram plus, gram minus adenoviruses, HSV, a little weaker but still high, fungi as well. Now let's move to the scientific proof, scientific evidence. In vitro studies are quite numerous, as you can see. This table shows you, I'm not going to tell you all the studies here, but about all the studies, but it's available. But I will focus on the most interesting clinical trials. So what can multilateral activity of ozone give us? First, antiseptics, broad spectrum, strong properties of killing bacteria, viruses, and fungi. It can also be connected with antibiotic therapy, and that can lead to higher efficiency of antibiotic therapy. And also, due to the regenerative properties, it can also help in rebuilding the cellular barrier and reduction of inflammation. Here I wanted to show you an interesting article that was presented in JCRS in 21. So it's a multi-center prospective controlled study of 4-stage assessing the efficacy of ozonated plant oil in eliminating pathogens from the conjunctival sac in patients before the cataract surgery. Majority of centers in Italy, 184 patients. Here are the results. The study showed that the use of liposomal ozonated oil led to the reduction of pathogens by 92%, as shown by the study. Almost 100% reduction. Very high efficacy then in using that solution. In terms of safety, only 3 out of 174 patients in the study reported topical undesirable side effects in the treated eye, limited to slight vascularization of the conjunctiva stage 1 and no other clinical symptoms. The acceptance of treatment was high. Almost 96% of patients assessed the treatment as very comfortable. 6 patients reported mild pain and 1 reported moderate discomfort. Moving on to the conclusions. The authors reported that the topical administration of liposomal ozonated oil in study population caused this significant decrease of microbiological burden on the conjunctiva that could lead to perioperative inflammation or infection. Tolerance of the solution was optimal due to its liposomal character, and antiseptic activity related to lack of toxicity and lack of allergy generation may lead to the conclusion that liposomal ozonated oil may be considered a safe and efficient mean also in at-home prophylaxis and prevention in and around cataract surgery. A very important feature of ozonated oil is the fact that it's active towards biofilm. We know that pathogens have the property of creating biofilm on medical materials that would make them resistant to antibiotics and immunological response. The essence of creating of the biofilm is a natural mechanism, and it's a significant obstacle in pharmacological treatment because it limits the potential of natural mechanisms of the eye and the antibiotic itself. It is estimated that the network bacteria may generate 100 times increase in resistance to antibiotic. Here you can see the efficacy of liposomal ozonated oil compared to the first chart shows the prevention of creating of biofilm in Staphylococcus aureus. The middle, Staphylococcus aureus, activity on bacterial cells within biofilm. And as you can see, also high efficacy. And third chart shows the efficiency in biofilm eradication created by Staphylococcus aureus. Again, high efficacy in every of these cases. We also know that patients with conjunctivitis are quite an important group of patients that report to ophthalmologist and family doctor. We also know that main reason for developing resistance is the incorrect differentiating diagnostics. So prescribing antibiotics in diseases in forms that they shouldn't be used, in viral infections, for example, or allergies. That is why antiseptics in general, and ozonated oil particularly, can be an interesting alternative to monotherapies in such inflammations. And in terms of insufficient response, when it's unsuccessful, and if it's bacterial inflammation, of course, then introducing antibiotics. In most cases, as we know, it's not going to be necessary. In the last 15-20 years, there is a campaign in the world choosing wisely, eliminating unneeded practices. For example, using antibiotics in intravitreal injections, preventive use antibiotics with conjunctivitis of viral nature, which is still done sometimes, unfortunately. Hopefully, we will be able to eliminate that. And then using antibiotics in problems with tear ducts in small children, this also cannot be justified. In 2018, I've prepared for Euretina the assumptions for the recommendations that were adopted about the antiseptic operations activities in intravitreal injections. It led to excluding the antibiotics in drops before and after intravitreal injections. These recommendations were quite widely accepted in many European countries, so definitely it is possible. We also talk about the same in terms of cataract surgery. Some countries don't use antibiotics in drops, for example, Sweden, also Denmark. In perioperative prophylaxis of endophthalmitis as well, and France to a certain extent. As you can see, antibiotics are not recommended pre-operatively. In most countries, it is recommended. A lot of countries still use antibiotics post-op, however. And then it's worth noting that such preparation, ozonated oil, is safe even for young kids. The study here shows or compares it to netilmicin, these drops to netilmicin, and the study showed comparable amount of side or adverse events. And here, this article from Italy proves that as well, 2 years ago. So it can be used with little kids as well. So main properties of ozonated oil: wide spectrum of activity, multilateral antiseptic activity that disables the possibility of resistance, then great tolerance by the epithelial cells of cornea and conjunctiva, and activity of fastening healing. If you're interested in infections, perioperative infections, this is the book we published last year. Very good source of this problem. particularly in endophthalmitis practice, and our article about first what is approved and some controversies about prophylactic operations in endophthalmitis treatments. To finish up, I would like to invite you to EVER Congress that will take place in Valencia at the beginning of November. These conferences are always the great place to gain knowledge, discuss scientific problems. Thank you very much for your attention.
Czy są pozostali? Tak, jest. Mamy pani docent Jarecka.
Docent Jarecka, Dr. Stopyra.
Sprawdzimy, czy mamy pytania na czacie.
Let's check if we have questions on the chat. There are no questions still. So I would like to start and thank you for wonderful presentations. I have a question to Docent Jarecka about, because personally I find these prolonged formulations quite interesting. I used to believe that eye drops are response to everything, especially in the context of anti-VEGFs. I thought that if we can be replaced injections with eye drops, everyone would be happy. Then I learned from many different studies conducted by companies that people really hate eye drops. And in glaucoma treatment, we know the low percentage of compliance or adherence. Even if they don't admit, they usually don't take eye drops on a regular basis. So we may think that eye drops are minimally invasive method, but their efficacy is low because of low compliance. And patients don't adhere, patients don't like eye drops, so maybe that's not the best way of treatment. Surgeries, as we know, are associated with high risk. So the question is, if the inserts preparations may be something transitionary, or maybe something that balances safety and risk. And it's interesting that people that deal with glaucoma dream of injections, and people that deal with retina dream of eye drops. Now we know that this is something that is dynamically changing. I think we have binatoprost, the greatest experience in binatoprost, but this is already on the market, but it is approved for a singular or a double application. It provides us therapy for maximally 1 year. So this is a direction in which this glaucoma treatment will go, but we are still waiting for something more perfect than implants that are being present. To me, well, because we need something temporary, because we know that patients won't be compliant to taking drugs, eye drops. We need some solution. Maybe laser therapy would be an answer here, because light study proved that laser therapy changes therapeutic ladder. For example, in open-angle glaucoma, it's the first-line therapy. The same with MIGS. In glaucoma, it develops very quickly, and we hope that these methods will be safe enough that they will soon replace eye drops. But in terms of inserts or implants, for me, the very interesting are subconjunctival implants. We don't open the eye and it works for 1 year. So we can do it even in the slit lamp, but we are waiting for another phases that allow us to assess efficacy in patients. Durista seems to be a bit Dissatisfactory. Thank you that you've mentioned laser therapy, because it seems that it's underappreciated method of treatment, having evidence proving that it works. And it's minimally invasive, as you said. So here we have a question from audience. Is BeamRing available in Poland? How long was the follow-up with punks and plugs? And are there any complications in tear duct? All these drugs, even with Durista, are not available in Poland. So information I gave you, I took from studies of the third phase clinical trial, so 1 year follow-up. In terms of punk and plug, there was no information. Maybe there was just the plugging of one tear duct, and the second one is without complications. So these drugs are not associated with high risk of complications or with adverse events. Thank you. A question to me, ozonated olej. Do you have ready-made preparations? Yes. Also drop, that's the name of this preparation. One more question to Dr. Stopyra. Victor, first of all, the question, if there is one formulation that we can use for all axial lengths. Yes. No? Yes? No, still we don't have the golden standard. The majority of the publications that are available differentiate the axial length. There are some formulations better for longer axial length and others are better for shorter length. Of recently, medium-long, medium, so the axial length that is medium is something that is new and it has been differentiated, but we don't have one universal formula. So if you had to summarize, which formula you think is the most accurate in all three groups? Which one works the best in short, medium, and long axial length? Maybe it will be a surprise for you. I won't tell you one out of the new formulas that I presented today. Well, maybe because the time that are, well, they are on the market for a very short time. So it wasn't enough time to test them perfectly. In short, for long axial length, Barrett. For short cane, for medium, no matter. Whatever we take is going to be okay. Even, well, all formulas will be available here. Thank you. We have to finish. There are no more questions on the chat. Again, thank you very much for wonderful presentations, and let's have a 5-minute break. Thank you.
Dear colleagues, it is my great pleasure to present a lecture on fundus-based AI algorithms for ophthalmic and non-ophthalmic applications. Here are my financial disclosures. None of them is relevant to the topic of this presentation. Let me start with saying that I believe that the future of AI in medicine and of course in ophthalmology is between known and unknown unknowns. This saying comes from Donald Henry Rumsfeld, who was an American politician and the Secretary of Defense under President Gerald Ford and again President George Bush. And he coined the term, and he said that there are known knowns. There are things we know. We also know that there are known unknowns. That is to say, we know there are some things we don't know. But there are also unknown unknowns. The ones we don't know, we don't know. So let's start with the first category of known knowns. They classify eye disorders. We are quite aware of different eye disorders like retinopathy of prematurity, diabetic retinopathy, age-related macular degeneration, just to name the few, that they present some characteristic differences and pathological features that led to the developing AI algorithms that are able to detect these disorders. And many of them are included in our textbook, Artificial Intelligence in Ophthalmology. You can see here the table of contents, including many different, not only retina, but also non-retinal disorders to find here. So let me shortly present what is known in this category of the ophthalmic disorders and AI algorithm developed to detect this disorder. Certainly, diabetic retinopathy is most studied disorder with nearly 500 publications on machine learning and diabetic retinopathy. Fortunately, we have a recent review from our group that was published just a few months ago. This is open access, so everybody can read it. And one of the reasons why diabetic retinopathy was studied so heavily is that we do have very well known representation of the fundus changes, so it is relatively easy to annotate the lesions, and we do have good classification of diabetic retinopathy, and finally, of course, the access to data sets of diabetic retinopathy patients on different stages of the disease. This led to the introduction of many AI-based devices, both in US and in Europe. In the US, there are 3 of such devices already FDA approved. In Europe, there are much more. We were able to find at least 13 such devices. This was published at the beginning of this year here. Only 2 of them are also registered in US. So it shows that the European system is certainly or has been much more liberal when compared to the American one. This is one of the interesting recent papers published in Ophthalmology Science this year, and this paper showed that one of these algorithms that are registered both in US and in Europe, AI system had a higher sensitivity for detecting more than mild diabetic retinopathy than either general ophthalmologist or retina specialist compared with the clinical reference standard. So here we can see at this table comparison between and the sensitivity, specificity with the AI model. For example, we can see it for from the bottom IR system with the dilation if needed, and we can compare it to the retina, non-retina or retina specialists. Well, it shows quite good sensitivity. The specificity was quite similar to human graders. Another entity is diabetic macular edema with over 60 articles on machine learning and this disorder. And again, we have a very nice review recently published in the Survey of Ophthalmology on that, so I will not discuss it in detail. In this review, they studied 38 studies. And they shown that they provided pretty good accuracy between 91 to 98%, sensitivity between 95 to 100%, specificity between 76 to 100%. And this is the figure from this paper showing that the algorithm trained to detect diabetic macular edema were more or less than 50% were based on color fundus photography and OCT. Then age-related macular degeneration with around 200 papers in PubMed on machine learning and this disorder. Then glaucoma with over 450 articles again on machine learning and this disorder. Here I would like to just mention our study that was presented last year at AVO, and we compared the accuracy of deep learning in detecting glaucoma using optic nerve head fundus photos versus OCT across different patients' populations, disease severity, and axial length. And interestingly, what we found that the photo-based deep learning glaucoma detection significantly outperformed OCT-based detection. These findings underscore the importance of understanding how patient characteristics, disease severity, and reference standard definitions influence the performance of diabetic of deep learning models in glaucoma. The next interesting disorder is retinopathy of prematurity, with nearly 70 papers in PubMed on deep learning. And one of the studies that was published 2 years ago in pediatrics showed the area under the curve of 0.98 with 100% sensitivity and 78% specificity. And the authors of this study concluded that incorporating AI into ROP screening programs may lead to improved access to care for ROP secondary prevention. Then myopic macular degeneration with 35 articles in PubMed on machine learning. And again, one of these papers here presented a very good performance with area under the curve of 0.97 for myopic macular degeneration and 0.9 for severe myopia. And deep learning algorithm outperformed all 6 expert evaluators. Then myopia, hyperopia. I was able to find over 65 articles on refractive errors, myopia, and artificial intelligence in PubMed. As you can see, the mean absolute error that was presented in one of these studies was 0.56 diopters based on the UK Biobank dataset, and 0.9 diopters based on ARETS dataset. Then macular hole with 20 articles on deep learning in PubMed, and one of the studies, as a matter of fact quite recent, from this year, presented area under the curve, very good performance, 0.96, accuracy 0.95, specificity 0.87, and sensitivity 0.94. Epiretinal membrane, not so many papers, but already 13 papers presenting quite good accuracy for AI model, accuracy 77% versus manual grader 75%, sensitivity for AI model, let's say 76% versus 64% for manual for human grader, and specificity 79% versus 92% for human grader. So it was concluded that AI model can serve as possible alternative for manual diagnosis in epiretinal membrane screening. Optic disc edema. This paper is well known. There are 12 papers found in PubMed on optic disc edema and machine learning. This paper was published in New England Journal of Medicine. And optic nerve atrophy with 17 articles. Central serous retinopathy with 24 articles, and here we see the results from one of this article that was published in the Retina Journal 2020, and here again we see that the overall accuracy of the AI model was higher than human graders. It was 86% versus 83% for one grader and 71% for the other one. Retinitis pigmentosa, again with 20 articles in PubMed on machine learning. Here we see the results from one of the studies showing that the model provided the highest accuracy compared to general ophthalmologists, retina specialists, but also when compared to the retinal specialists and the IRD model. Then also regarding the precision, it was better than any other mode studied in this paper. Myelinated nerve fibers, we have only 2 articles on machine learning. One of them published last year, and in this study authors developed AI model to identify 10 retinal disorders, and they shown the sensitivity of near 90%. They differentiated 10 retinal diseases with accuracies from 95 to 99%. Now we will move to non-ophthalmic disorders. It is known for many years that the eye is the source for example, as a part of the central nervous system, is a source of the information about the central nervous system, but also can be used as a source of information about for cardiovascular disorders, based on that this is the only part of the human body where we can analyze the vessels that are located on the retina with the optical methods. So here I collected different disorders that were shown that they can be diagnosed based on the AI algorithm using fundus photo, so including Alzheimer's disease, Parkinson's disease, stroke risk of heart attack, systemic hypertension, chronic kidney disease, peripheral arterial disease, anemia, hepatobiliary diseases, and sarcopenia. Here's one of the examples. This is the study on the Alzheimer's disease, and this study shown, it was published last year, very good accuracy of 84%, sensitivity 93%, specificity of 82%. And then we have the category of unknown unknowns. So this is the example. This is the study from 2018, well-known study that for the first time shown that the fundus picture can be a source of information about the age, gender, smoking status, hemoglobin, glycosylated hemoglobin level, body mass index, and systolic and diastolic pressure. And from this time, it was already confirmed in several studies, so we know that it's true. And very recent study published just a few weeks ago from JAMA Ophthalmology, showing the accuracy of AI in estimating best corrected visual acuity from fundus photographs in eyes with diabetic macular edema. So for the first time, it was shown that AI can estimate best corrected visual acuity directly from fundus photographs in patients with DME without refraction or subjective visual acuity measurements, often within 1 to 2 lines on an ETDRS chart supporting this AI concept if additional improvements in estimates can be achieved. So presently, it is possible to, based on the fundus photo, to say if the photo belongs to the man or a woman. So we can simply determine if that this is a man, and the age of a person. He is 67 years old, non-smoking, without diabetes. He has BMI of around 24, blood pressure of 120 to 85 millimeters, and in the future probably will be even say more based on just a simple fundus picture. So, in conclusion, today we are already able to use fundus pictures for diagnosis of eye disorders, of some central nervous system disorders, and some systemic disorders. We can also use it for evaluating some demographic data, like a sex, age, or race. And probably this list will be soon much longer. And so at the end, I would like to invite everybody to our International AI in Ophthalmology Society. The registration is free. We have a great group of experts who create international council. And I would like to thank you so much for your kind attention.
Good afternoon, my name is Ineo Brukowski, and I'm going to present you selected innovations in optical coherence tomography. I'm going to present the results of the studies that were performed in my group at the Nicolaus Copernicus University, as well as the results that I found in the reports of the other people. I want also to disclose that I have no financial interest in the technologies that are presented in this talk. OCT is a modality that measures light which is back reflected or back scattered from the internal structures of the eye. The principle of operation is similar to that of ultrasound. However, we use here the light except for sound. And because there is a huge difference between light and sound, we have to use interferometry technique. The interference fringes are detected by the detector, and they contain information about the distribution of light, which is back reflected or back scattered across the depth. And if we try to scan the eye or the sample with the light beam and the transverse direction, then we can generate either the cross-sectional image or the whole volumetric image. If our system is fast enough, we can perform so-called 4D imaging when we acquire multiple volumetric images over time. The scanning procedure for the diagnostics and retinal diagnostics before the OCT were most related on fundus photography or angiography, where there is no three-dimensional information or depth information. The first paper on OCT was published in 1991, so it's already over 30 years when the OCT develops, and the first presentation was actually using human retina ex vivo. Over the years, there were three generations of OCT technologies. The first one was time domain, where you have to move the reference arm in order to get the depth information. There's also Fourier domain detection, which is much more effective and efficient, which can, in spectral OCT, you can use the spectrometer, or in swept source, you use the rapidly tunable light source and the point digitizer. The advantage of OCT is that it can achieve near quantum limited sensitivity, which means that you can detect very low amounts of light. For example, 1/10 billion incident photons. It has very high dynamic range, high spatial resolution, and can offer actually high performance systems which provide information which is clinically relevant. OCT is widely used in clinics all over the world. However, OCT was also transported during the space missions in order to monitor the health of crew's eye at the International Space Station. OCT, from technological point of view, is a rich combination of engineering disciplines such as computer science, electronics, electro-optical devices, fiber optics, telecom devices, medical devices, optical and mechanical design, as well as software development. And this multidisciplinary nature of this technology is a major factor in fostering innovations. OCT revolutionized the diagnostics of retinal pathologies because it provides information. It has extremely high axial resolution, and it provides information what's going on at different layers. And this is the image of the healthy eye. You have the fovea and optical disc, and because it can provide the images of in vivo images, so it's sometimes called optical biopsy. It's a clinically very frequently used technology. You can see that it can check the architecture of the retina and different retinal. The performance of OCT systems changed a lot over the years. You can see that the speeds, the number of volumes, the sensitivity, depth range, and resolution changed a lot. There are huge improvements in developing the systems with different contrast mechanisms, and this allowed us to generate the images of better and better quality. And here we can see comparison of images of the cornea, of the crystal lens, and the macula. There are also some functional extensions. You can provide multimodal imaging. You can enhance also software in order to provide motion correction, feature segmentation, biometry, or some automatic disease detection. OCT allows to generate the cross-sectional and volumetric images with extremely high sensitivity, and in this study we wanted to visualize the lenticular opacities in age-related cataracts. So we developed the system that was deployed to to the lab of Pablo Artal in Murcia, Spain, and this was able to the system was able to generate to acquire the information about the architecture of the anterior segment of the eye, in particular of the crystal lens. In this movie, we see the lens false in false color scale, the opacities in the crystal lens of the cortical cataract. The system allowed us to generate the images of the lenticular sutures in vivo. We also used the system to characterize the opacities in cataract suspects and cataract patients. So we can see in these images, in these examples, that the cataract shows up as a hyper reflective regions in the crystal lens, and the lens becomes less homogeneous, and there are also some vacuoles, hyperreflective vacuoles, and also the nucleus can become hyperreflective, which is a sign of the nuclear cataract. And this enabled us to perform the cataract grading, or to acquire information which is objective evaluation of the intraocular scattering. You can see the scattering increases with the grade in the LOX3 scale. We also employed tunable focus technology, the lenses with tunable focus, in order to enhance the quality of the images, and by performing the tuning the lens focus, you can see that we can significantly increase the quality of the images by performing so-called focus stacking, and this enables us to see the signal below the crystal lens or in front of the retina, and this is actually the anterior and posterior vitreous. In another study, we used the precise focus control in order to visualize the vitreal structures in the anterior vitreous and posterior vitreous, and this gave us three-dimensional information about opacification of the vitreous. We developed the method in order to quantify the opacification, and we can see here that with the age there are different types of opacification in the vitreous. There are some membranes, there are some liquefaction areas or volumes, and there are some opacities which actually look like, in the cross-sectional images, look like spots, like dots, but these are actually some three-dimensional structures. And so we quantify this, and we see that the signal in the lens across the age also increases with the age, but the signal from the vitreous also increases with the age. And this allowed us for objective quantification of the lenticular and vitreous opacities. Apart from scanning systems, you can also develop the systems which have extremely high spatial resolution, and these are called full field OCT. And in full field, we don't use point scanning systems, but you illuminate the sample just with the light and detect with the camera the entire volume. And using this, the people from France were able to provide very high resolution images of the cornea, different layers of the cornea, of the epithelium, endothelium, stroma, and also there is they were able to see the single cells, the keratocytes, also with the nuclei of the keratocytes, and by modifying the scanning geometry in full field system and providing the adaptive optics, they were able to visualize the retina in vivo with very high spatial resolution in order to resolve single photoreceptors. And another approach, which is developed in Warsaw by Maciej Rutkowski, they use stock method and computational refocusing to obtain extremely good images of the retinal structures without any very costly adaptive optics approach. Apart from providing high-resolution OCT images, the studies or innovations in OCT also focus at providing or enhancing the field of view. And the conventional optical coherence tomography or angiography imaging covers mostly like up to 30 degrees of the retina. However, wide field offers detailed cross-sectional imaging of the peripheral retina. However, it's not very systematically used in the clinical practice. The technology is rapidly developing. There are a few devices on the market commercially available, and they provide the field of view of up to 200 degrees. Actually, this image is the montage. However, here, if we provide also the information of angiography, you can identify different features of diabetic retinopathy. OCT was also used for enhanced, not only in transverse direction, to enhance the performance, not in the X direction, but also in the depth direction, by utilizing the light sources of the specific coherence length. You can generate a long-range swept source OCT, and this enables to visualize the cross-sectional images and provide information about cornea, crystallines, and also the retina. And this provides information about the optical biometry. You can measure the intraocular distances. Few actually devices have been introduced into the market and that are used before the cataract surgery. So in the future, maybe we will be able to observe the images like those composites images. These are not really like true images. This image was composed by two anterior and the posterior systems from Heidelberg, and this is a very nice visualization of the human eye tissues using the histology, which is colored by OCT with the OCT scale. In another interesting application is to use the OCT during the operation. There are several instruments for intraoperative OCT, which are microscope mounted. However, this approach, you put the OCT module with the microscope, but there is no access to the real-time information. However, recently there were a few microscope integrated OCT systems, and this in the future we believe that can provide also real-time intraoperative OCT, and also some OCT compatible devices or surgical devices can be introduced in order to support the surgeon during the OCT. Can be also combined with the virtual reality in order to help the doctors during the surgical operation. We can observe in this movie that three-dimensional information about the cornea can be used in the tools which are maneuvering and to help to see what's going on during the operation. Conventional OCT systems are tabletop instruments which are operated by trained staff, and the systems require mechanical stabilization of the patient's head. However, the engineers from Duke University developed the system, developed the OCT systems together with the robotic arm in order to perform so-called autonomous OCT, where the freestanding individual is scanned and the motion is actually followed by OCT instrument. This enables which we can see in this movie, that we can perform OCT imaging, and the position of the scanning head is follows the movement of the eye. They use different cameras in order to provide information about the position of the eye and of the head. However, we want to make also the systems, the OCT, more democratic. It means that it can be more available to people. So there were also some studies that showed that the system can be made portable, can be made low cost. For example, in the suitcase, can be also very low cost or very easy to put in any environment in any place. So this system from some company, actually the weight is 5 kilograms, so it can be put practically everywhere. And this leads us to a new applications or a new generation of the instruments which can perform at-home OCT, or these are home-based OCT or self-OCT. So it means that the patient can do the OCT imaging at home and monitor the health of the retina. In this case, for example, there's a startup company, Natal Vision, which developed the patient self-operated system. It's AI-powered. And the system was FDA granted for marketing authorization in May 2024. And this uses actually the scanning, and the data are transferred to the monitoring center. It uses also, it's powered by artificial intelligence, and the doctor can make some assessment. Another example is the device which is called, it's based by Visotech. The company was acquired by Heidelberg. It allows to perform self-examination, and it's low-cost full-field OCT. So you can see that the image can be done like that, and there's also some kind of system that can be attached. Another approach used downsample scanning pattern. In order to provide, it's MIMO, it's the company from Switzerland, it's MIMO OCT, and you can see that you can put the head and monitor the health of the retina. In this study, the people from Switzerland also checked the image quality was sufficient in order to extract valuable information. So you have to remember that in the future there will be huge impact of the artificial intelligence in analyzes the images and to help the doctors to diagnose the diseases. So to sum up, the technology enabled the paradigm shift in ophthalmic diagnostics and the therapy, and all these advances in OCT have been impactful from the economic point of view, scientific point of view, from the clinical point of view, and also from the patient care. And those innovations stimulate fundamental research and clinical practice, and these technological advances provide platforms from future OCT instruments, which will be featuring novel applications and providing new generations of diagnostics. So thank you very much for your attention, and I'd like to acknowledge also my group and also our collaborators and the companies that support us. Thank you very much.
Good afternoon. I would like to welcome everyone to the conference Science and Tech Innovations in Ophthalmology. I would like to thank you for your participation, and special thanks to Professor Grzybowski for organizing this event and for my invitation. My name is Maciej Wojtkowski, and today I would like to talk about our efforts at the International Eye Research Center in order to introduce new imaging methods in ophthalmology. As you are aware, most of the known eye diseases have not been fully understood in terms of etiology. We don't know the reason of such diseases. Moreover, a majority of effective treatment procedures have been introduced in the last few decades, and this revolution in ophthalmology is still underway. Many breakthroughs in the last century make it possible that we were able to introduce new therapies into ophthalmology. Thanks to them, we can affect the metabolism of the eye, and consequently, we can prolong our life, vitality, and improve quality of life for people of the advanced age. The therapies that are being developed right now are regenerative therapies, gene therapies, protein regulators, and robotic surgery. All these therapies can be introduced effectively and quickly if they are accompanied by appropriate technologies to test the efficacy of these therapies. At the moment, imaging methods that exist and which are used in ophthalmology are inadequate to assess the condition of the retina after very delicate therapies, because we don't have good quantitative methods that would be able to analyze retinal functions. A tool that is commonly used in ophthalmology is OCT. Of course, there are many other different methods of imaging like fundus, photography, autofluorescence, indocyanine or fluorescein, methods used to image the anterior chamber of the eye, but OCT is used commonly in about 30 cases in intensive clinical practice in ophthalmology. Why? Well, the reason for that is simple. Lesions in the fundus or in the anterior chamber are manifested with large changes in morphology that can be easily captured by imaging and quantified and used as specific biomarkers to monitor the course of the disease or the treatment, or they help us diagnose retinal lesions early enough. However, if we're thinking about the functional examination of the retina, the gold standard here is a very primitive test, so the visual acuity test, which is performed in almost 100% in clinical practice. More sophisticated test, that is visual field test, is performed only in 10% of clinical practice. Objective tests such as electrolithography, action potentials, microperimetry are unfortunately used in less than 1% of everyday clinical practice. So this is an insignificant part of ophthalmic care, and we would like to change that. We would like to monitor the treatment of eye diseases at the functional level with the methods that are non-invasive, non-contact, fast, methods that can be used all the time, that are cheap, that can be used in a higher percentage of cases in clinical practice. And that's why we've identified two different mechanisms that can help us introduce such methods. The first one is molecular interactions on the retina, as a result of which, imaging with molecular contrast, we are able to get information that is relevant to the chemical process of vision. The second mechanism is so-called optoretinography. This is a phenomenon described quite recently. Here, photoreceptors, so our photosensitive cells in the retina, change their morphology under the influence of light. These changes are very small, but possible to be observed. And now I will tell you about these two methods, how we want to use them for imaging. To simplify it, we can say that the first of these methods of molecular imaging is a form of autofluorescence, but with two-photon excitation. And this method will give us information about the active pigments on the retina, that is, the ones that are actively involved in the process of vision, as opposed to classical autofluorescence imaging. when it comes to electroretinography, which is a gold standard at the moment in functional imaging of photoreceptor activity, we would like to replace it with an optical method called optoretinography, which will also provide us with the information about local changes in the photoreceptor activity, but without the need to adaptation to the darkness, without performing long procedures that are necessary in electroretinography. The first method that we are developing is the molecular imaging of the retina. In this technique, as I said before, we are trying to extend the capabilities of autofluorescence, but in our case, we use fluorescence with two-photon excitation. What does it mean? It means that in the classical autofluorescence, we can excite the eye, or we can excite retinal molecules to glow with light no shorter than 450 nanometers. Why? Because this is, well, due to the strong absorption of the anterior chamber or cornea, and the lens of the eye for wavelengths shorter than 450 nanometers, these radiations become dangerous to our eye. Then we can use light with longer wavelengths, such as infrared, but with the proper power density, that is, with the proper and short pulse, and with the sufficiently small hole, it can be seen by molecules as the ultraviolet light, and in this way we can excite, we can stimulate retinosomes. Retinosomes are components that are active in the cycle of the vision, in the biochemical process. They are condensates of retinoids in the pigment epithelial cells. That's why we have access to real biochemistry of vision. We can look into this process that we call phototransduction. And here is the result of such an imaging. It doesn't look very encouraging. We can see that we have little fluorescence light. We observe less than 1 photon per pixel, but in the second channel we observe a reflected channel. And we, after averaging many of such images and reducing the effect of motion, we observe pretty good autofluorescence image. The experiments were possible thanks to the help of our colleagues from the institutes from Wrocław, who designed for us special laser, allowing us to control the parameters in such a way that the light we provide is safe to the eye, but at the same time this light has high energy, and that this phenomenon is observed. And here is the example of the result from our first publication. We see here autofluorescence images. We compared them to classical single photon autofluorescence, and we compared it to the fluorescence images that came from animal models, where we can control the accumulation of retinosomes, and in this way we can indicate in which spectral regions we are able to get a better signal from the components that we are interested in. The second method we've been developing is optoretinography. Here, well, with the eye that is adapted to the darkness, well, when we shine to this light in one single pulse, we see that there is an elongation of photoreceptors. This is the diagram that will prove that. When we start measuring the distances in the photoreceptors, so the length of the outer segments of the receptors, we shine the light, and then we see a sharp increase of their length. It was first observed by Hillman in 2016. We repeated these experiments using our new technique that we were developing, and we got very, very similar results. We were encouraged, so we decided to introduce another measurement protocol that is more practical. Namely, we were shining light repeatedly. It was a flashlight, so flicker, and we expect photoreceptors to respond to these flashes with the change of their length, as here you can see in the video. And we measured photoreceptor response signals that correspond to the stimulation frequency. Look, these changes are really small. The 4 nanometers in amplitude to 4, but after Fourier transformation we can get a very decent signal-to-noise ratio. And we repeated these measurements for different frequencies to confirm that this phenomenon is associated with the excitation. Here you can see the effect of spatial recognition. So if we displace the letter E, we can identify the photoreceptor responses for this particular optotype. In this way, we also were able to identify individual receptors. It was made possible by the introduction of the new method of imaging called STOC-T, spatial temporal optical tomography, the technique which is the development of OCT, but with totally different technological system. We have a full field illumination without scanning of the beam. We added several additional elements to control the spatial coherence that is not controlled in OCT. And thanks to that, we have high quality images of high contrast, of high resolution from many different layers of the retina. And I would like to finish my presentation. Thank you very much for your attention. I would like to thank my colleagues, my team from the optics group and biophotonic group, and I would like to thank our colleagues from ophthalmology departments and from other fields of expertise and for funding. Thank you very much. Let's start the discussion. Please ask questions on the chat. Maciej, you are with us because Professor Wojtkowski suggested that he will be now traveling to the United States. Great, you're here with us. You've managed to be with us. Yeah, I did it. So Irek is missing, the second speaker. Both professors are maybe not well recognized. They are physicians, not ophthalmologists, but they belong to the most prominent scientists that deal with ophthalmology, not only in Poland, but around the world. They are top in terms of imaging in ophthalmology. They are prominent scientists. So thank you for your great speeches and great presentations. Irek may join us. We will see if he is able to do it. He probably has reason not to be with us today. There are no questions. Andrzej, I was listening to your presentation and I really liked it. So thank you for gathering all the information, because I don't really follow everything what's going on in terms of ophthalmology and using AI. But I'm wondering, because you said that in glaucoma, the result was that the better results were obtained by fundus images. Yeah, it was amazing. Yeah. Were these normal images or stretoscopy images? So it was the optic nerve, just fundus images or optic nerve images? No, the normal images from fundus cameras. Recently, for some years, there were examinations in which AI algorithms were trained in OCT and on fundus images. And in ophthalmology, OCT gives us more information than a fundus image. It seems to be more complex imaging. By the way, I proposed such a study because in the United States, they have great data sets, and in the same patients, we had OCTs and fundus images. So we had this data, and here we were working on the same, we trained AI on the same algorithms, and fundus images gave better results. Did you use the fundamental analysis, so disk to cap, and you were looking for all parameters that were in OCT, or you based it on the scans only? You based it only on 3D scans or on FAST scans? No, on FAST only. I cannot now tell you, because we did it several years ago. I don't really remember, but the methodology was exactly the same like in other studies that used OCT scans to train AI algorithms. So it was not to show that the additional features may help to have better algorithm results, but the aim was to compare these two different data sets. I wanted to show in my presentation that fundus image, even though by ophthalmologists it is regarded as not very important, because it's people say that it's a very simple imaging, but actually it has and it can provide many different data that can belong to the category unknowns. To the category of known unknowns. So to the systemic and neurodegenerative disease that we examine now, but also it can belong to the unknown of unknowns, because the demographic data, who could, predict what was shown by the Google group in 2018, that based on fundus images we can determine the sex or age of the patient, or BMI, smoking status. So it seems that there are some data that we are not aware of that we can get from such images. I heard recently that even if we take into account full analysis from OCT and optic nerve analysis, still the diagnostic efficacy for glaucoma is lower than if we use images only. So maybe too much information isn't beneficial, because we have specificity of people. I mean, we have many different variations, and that's why OCT is maybe too complex, and the OCT may, in a way, affect the statistics. I mean, it's very interesting. That's why I asked about it, how you did it. I look at it differently, because you are now developing scientific tools, but they are more sophisticated. You are trying to open the new space, the new areas for us, and I'm looking for tools that can be used massively, that can be used for screening of the patient. So I'm looking for the tools that can be used not only by ophthalmologists, but can be used by GPs. Even a GP should be able to take the image of the eye and diagnose the patient. So it's For example, GP could diagnose Alzheimer's disease, the risk of Alzheimer's disease, hypertension. So fundus image is cheaper, and better than OCT. At least at the moment, we don't have questions. We have to finish because we are beginning another session in 2 minutes. So Maciej, again, thank you for your lecture. Thank you for your invitation and for organizing this conference, because the topic is very interesting and great topics. Great interdisciplinary meeting of ophthalmology scientists that are so knowledgeable about ophthalmology, even though you are physicists. We can learn from each other. Thank you very much.
Good afternoon, everybody. Thank you very much for giving me the opportunity to give a talk today about innovations in ocular genetics. I will focus mainly on progressive inherited retinal disorders. My name is Christina Zeitz, and I'm a researcher and co-leading with Professor Isabelle Oudot a group in the Department of Genetics at the Institut La Vision in Paris in France. So we are working on inherited retinal diseases, and they are characterized because they are clinical heterogeneous. There are stationary forms of diseases, but also progressive diseases. Upon the stationary diseases, we have congenital stationary night blindness, so patients have problems during dim light conditions, and achromatopsia. And the progressive diseases are characterized not only by a dysfunctioning of the retina, but also due to progression of the disease by dying photoreceptors. So we can discriminate, for example, patients having more visual, periphery visual field constrictions, and they are having retinitis pigmentosa, and this can also at the end lead to complete blindness. But we have also cone dystrophies, which are characterized by central vision loss, like you can see here, and then the patients unfortunately can also become complete blind. Also, on the genetic basis, these diseases are very heterogeneous. Today, there are more than 300 different gene defects described, and still a lot to be discovered. The genes responsible for the disorder, they have mutations, and then they lead to problems in the visual cycle. They code for genes important for the phototransduction cascade. They are important for cilia function, for example, and for the structure of the photoreceptors. They may be implicated in RNA splicing and transcription factors. The pathophysiology is not always well understood, so there are still remaining questions, and also, as I mentioned, remaining genetically unresolved cases. The role of epigenetics and other modifiers are largely unknown. There are increasing therapeutic trials since 2006, and therefore it's very important to work in this field. There is, for example, the first gene therapy approach, which has been made on RPE65-related inherited retinal disorders. And since then, now the product is approved by FDA and also in Europe by EMA. So, in general, If you would like to treat patients with the disease, the genetics is very important, which helps then to prepare patients for clinical trials, but also to better understand the pathophysiology and the underlying genetic mechanisms. So how do we proceed at our institute? So first, the patients are seen at the Piensman Hospital. They are clinically very well characterized by ERG, fundus, registration, OCTs, and so on. And then the patients were asked or are asked if they would like to participate in a clinical study, in a research study, and then they get blood and the DNA is collected by our group to perform precise genotype and functional studies. This may lead to novel or known gene defect identification, to phenotype-genotype correlation, and of course to a better understanding of the pathophysiology and prepare patients for future clinical trials. In detail, how do we proceed in the laboratory? So we have DNAs from patients, and for some of the polygenic disorders, we still perform Sanger sequencing in the laboratory. But for most of the cases, we perform targeted next-generation sequencing on a next-generation sequencing retina panel covering more than these 300 different genes already implicated in inherited retinal disorders. If we do not find mutations in the known genes, we perform whole exome sequencing or whole genome sequencing. And together, we identify in 70% of the cases mutations in the known genes. For the new ones, we perform functional analysis by performing in vitro studies using COS cells, fibroblast cells, or iPS cells. And then we have also in vivo studies, which we can do by performing mouse studies or zebrafish modeling. Then we investigate the whole cohort for unresolved cases, perform prevalence studies, and this will prepare together patients for novel therapies. So then what we are doing, we deliver prevalence studies. So we showed that our cohort consists mainly of rod cone dystrophy patients. However, we have also a lot of cone dystrophy patients or syndromic cases. Syndromic cases means the patients have not only retinal defects, but also other organs may be affected. Furthermore, we can do genetic-based prevalence studies, and here it is important to identify the major gene defects of a cohort. We showed that ASH2A as well as EYS and RP1 are major gene defects in our cohort. So these are important gene therapeutic targets for the future to develop therapies. Then we also showed that by our studies, we identified novel genotype-phenotype correlations. It was interesting that variants before have been described in CC2D2A, and they lead to a very severe syndrome like Meckel-Gruber syndrome or Schubert syndrome. However, our cases presented here showed only a non-syndromic rod cone or cone rod dystrophy. Actually, this was an interesting family because these patients showed not only rod cone dystrophy or cone rod dystrophy, but in addition to that, they showed proteinuria and not only rod cone dystrophy, but cone rod dystrophy. And this was due to the genetic defects they carried. The first family had only a variant in CCDC2A. The second patients having proteinuria, but also more rod cone dystrophy, showed also variants in pupillin. Pupillin has been implicated in these kind of proteinuria diseases. And then the third family member had achromatopsia and rod cone dystrophy, explaining the more severe phenotype on the retina, and in addition to that, proteinuria due to tubulin variants. So sometimes you not only have one gene defect in a family, but also other gene defects may be present. This is also a very interesting novel genotype-phenotype correlation we made by our studies, showing that variants in CLN3, which has been previously identified as the underlying cause of Batten disease, we had cases where there was only a rod cone dystrophy present. And our genotype-phenotype correlation revealed that several mutations may show the classical severe Batten disease, but there were some other mutations leading mainly to a rod cone dystrophy. But this is a very important study because it's very important for diagnostics, and it must be considered very carefully, because if you are telling the patients, you have CLN3 variant, some of the families will panic because they will know that they will get Batten disease. But however, perhaps in the future we can say, if you have only a combination of specific mutation, it may be that you will not develop Batten disease, but you will have only a rod cone dystrophy. But this may be very difficult to diagnose, so you need to diagnose this with care. Then we identified also novel genes, for example, CCDC1, it's a mitochondrial gene coding for mitochondrial proteins, and it leads to autosomal recessive rod cone dystrophy, and it is nicely located in the photoreceptor as shown here by immunohistochemistry studies. Then, so how do we proceed now if we are interested to further reinforce a candidate gene to be the underlying gene defect? We cannot take out the retina of a patient to prove that this retina is non-functional and that it's due to a specific gene defect. However, we can take skin biopsies of patients, generate fibroblasts, reprogram them to iPS cells, human-derived stem cells, and then we can characterize them, and then we are able now in our laboratory to differentiate them to retinal organoids and retinal RPE cells from the human iPS cells. And this, of course, allows you then to characterize the phenotype, to compare the phenotype with the unaffected patient and to see if there is a difference, which helps you to better understand a disease gene defect. So this work has described more recently when we identified a novel gene defect in patients with progressive inherited retinal disorders. Here you have fundus pictures, FAF pictures of patients having rod cone dystrophy, also called retinitis pigmentosa. We worked on this family forever. So we performed direct Sanger sequencing in 2010 in this affected male patient, originating from a consanguineous family. This did not reveal any mutations. Then we performed area comparative genomic hybridization to see if we identify large deletion or duplication. This was also negative. Then we performed targeted next generation sequencing, at this time in 200 genes. We didn't identify variants, and in 2014 we performed whole exome sequencing, and then only in 2020 we performed whole genome sequencing. Whole genome sequencing revealed a homozygous region on different chromosomes, and especially in one on chromosome 15. And in this chromosome 15, which can be seen here, there was one variant identified in this family, it was C910-7 G to A transition, and with an unknown protein consequence. This variant is found in an intron close to an exon, but it doesn't affect the conserved splice sites of this gene UBAP1L. This variant, however, co-segregated nicely in this family, and subsequent sequencing, Sanger sequencing on other family members, and also targeted sequencing, next generation sequencing, revealed 3 other families harboring mutations in UBAP1L. The gene is located in a very interesting region, which is enriched for the retina expression. We identified several families from Tunisia having mutation in this gene, having either rod-cone dystrophy or cone-rod dystrophy. Subsequently, we are now interested, as I said, to further identify the function of this gene or the pathogenic mechanism. So, as said, we use fibroblasts to make iPS cells, and we made this here for an unaffected patient of this family having this -7 variant, and performed iPS cells, and we have now available retinal organoids and RPE cells from these both subjects. Expression analysis of this gene UBAP1L revealed that the gene is expressed in the retina, and more specifically also in RPE cells and in retinal organoids derived from human subjects. In zebrafish as well, the gene is expressed in the retina, as shown here, and more specifically in the photoreceptors. And this has been also validated here by immune studies. Then, using our retinal organoids, we validated also that the variant, the -7 G to A variant in UBAP1L, leads to an altered transcript, actually to a longer form. So here we made RT-PCR experiments and showed the transcripts for the normal situation. The patients showed the mutant alleles, which are a little bit larger, difficult to see, but we proved this by sequencing. And interestingly, the brother, which was heterozygous, showed the 2 alleles, the transcript having the longer form and the shorter form. So indicating that indeed the pathogenic mechanism is that it leads to a longer transcript and an altered UBAP1L protein. The protein itself, it codes for a protein important for ubiquitination, having a superdomain, and you can clearly see here that the superdomain is consisting of 7 alpha helices, and all the mutant proteins lead to a shorter presence of these superdomain of these alpha helices, and that might be the pathogenic mechanism. In addition to our publication, which came out this year in January and in 2024, 1 month later, another group identified similar findings, that also mutations in their cohort in UBAP1L lead to autosomal recessive retinal degeneration. The families came from Hungary, from the United States, from Israel and the Netherlands, and they identified similar mutations than us, but also 2 novel ones. The phenotype was quite similar, also retinal dystrophies. And this brings me now actually to the end, because now we have limitations, but we are still interested to better understand the pathophysiology. So we have a zebrafish model, we have the iPS cells model, and we would like to characterize them better. In addition to that, we plan to do CRISPR-Cas9 base editing, which seems to be a better control than unaffected control, having the same background as the patient. We want to do RNA sequencing on RPE cells of the patient and the control, and also RNA sequencing on the retinal organoids, proteomic analysis and histological phenotyping, and of course better characterize the zebrafish model functionally. And in the future also we would like to resolve the 30 remaining patients with missing gene defects by similar high throughput approach. So this brings me to the end, saying that this work was of course not be possible with the help of so many people implicated in our work. Thank you very much.
Dear ladies and gentlemen, thank you very much for giving me the opportunity to present our work in this interesting symposium. We are focusing on innovation in corneal diagnostics. My name is Thomas Fuchsluger. I'm the department chair of the University Eye Hospital in Rostock, Germany. So the background of our work is that the release of a donor cornea into the operating room mainly is dependent on one main criterion for the functionality of the endothelium, and that is the central cell count of being at least 2,000 squares per millimeter, 2,000 cells per millimeter square. And that criterion has been in place since the development of the corneal culture system in the 1970s. This is regardless of it is a cold culture, so hypothermic, or an organ culture system, so a cultivation between 32 and 37 degrees centigrade here of view into an incubator. In the organ culture system, the cornea floats in the in the culture medium. As you know, we focus on the endothelium, and the back surface is very crucial for maintaining to maintain the clarity of the corneal stroma. So there are several ways to analyze the endothelial cell density. So this either could be manual cell count using software and a photo, or this could be using artificial intelligence with a kind of suggestion for the cell count giving in a square that is defined either automatically or manually by the investigator. So the two basic questions: which other parameters could be useful to better characterize the quality of a donor cornea, and could this lead to a high number of donor tissue available for corneal transplant, and could this ultimately lead to better outcomes for the patient after transplantation? So we were looking into a paper published by Gary Yam of Jodmita's group out of Singapore, characterizing the human transition zone, the niche between the peripheral endothelium and the limbus, so to say, which revealed putative progenitor-enriched cells that could be progenitors of the corneal endothelium. So in this work, there had been this zone identified that revealed specific stem cell markers, and we wanted to show if this could be useful for use in a corneal culture and a corneal evaluation system. So our goal was to establish a novel method for sterile evaluation of the corneal endothelial transition zone based on an examination with the Rostock corneal module in order to establish an additional criterion for EC evaluation with the aim to eventually reduce the discount rates of donor corneas So of those that do not show 2000 cells per square millimeter or more. And this would answer the question, if a donor cornea that shows less than 2000 cells per square millimeter and above or good average endothelial progenitor cells would be suitable for regular scheduled surgery and only for an emergency case. So to further characterize the endothelial transition zone and its progenitor cells, we used a confocal laser scanning microscopy and also electron microscopy. So the background of the story is that the Heidelberg Retina tomograph was upgraded in our department to visualize the cornea. This work was done by Professor Stave, and it was then called the roster cornea module. So in-house research has been since done to further develop and improve that cornea module, and a modification to use the system for donor cornea evaluation. So those are the early images, as you can see below, of the development of the roster cornea module, and up to date, where you can see the cornea module, which has now gone out of production. So this was all developed by Professor Stave, who passed away like 3 years ago. So there were some major technical milestones for patient examination, which was called internally roster cornea module RCM 2.0. That included a complete redesign with a 2 piezo actuator based focus shift technique on a joystick and modified optical geometry, moving the objective lens and not the contact cap, as you can see here. So it's not the contact cap that has been moving, but the objective lens within. So here you can see some images, representative images and clinical use. So it is possible to screen the entire cornea from back to front and to identify certain kind of landmarks, and to also follow certain cells or nerves. So the methodology to optimize the RCM 2.0 was to set it up for an ex vivo cellular imaging for donor corneas. So as you can see on the left hand side, this is the normal position of the RCM for patient examination. So the current design only allowed coarse manual adjustment of the initial focus by changing the contact cap position, but we introduced a motorized drive to adjust the focus in the RCM 2.0. So the motorized drive now allows precise visualization and evaluation of the donor cornea structures. So we put the examination unit horizontally, then put the contact cap on, and then kind of adapted this to the motorized drive. So as you can see here in a larger magnification, the laser scanning system is equipped with a 6-axis precision piezo stage for microscopy of the specimens, for example, a donor cornea, and now you can be very flexible, and the cornea is fixed to the hold by some sort of suction. So we then focused on evaluating the cornea endothelial transition zone using the RCM, as I mentioned, and we were able to visualize several structures, such as the trabecular meshwork and the endothelium, identifying the transition zone. So here you can see those images. Furthermore, we can kind of further go in and identify certain characteristic structures just below the trabecular meshwork in the transition zone, which we identified as progenitor cells. So those are irregularly shaped polygonal cells, as you can see on the right-hand image C. And the question is, could we also validate this by certain stem cell markers? So we went in using kind of published stem cell markers such as AGBC2, LGR5, SOX2, ZO1 for the cell borders, and this could further validate the progenitor cell character of those cells in that specific area. We looked into some more like nestin, vimentin, and so for this we were able to visualize select areas and to obtain proof of the progenitor cell character of those cells in that identified transition zone. This is compared to other publications from Jan and Yu et al. Published in those papers of those colleagues as well, and we also looked at some more, as you can see here in that right-hand side box. So furthermore, we examined the structure using electron microscopy, and so this is much more going into the enlargement of the cell structure, and of course it comes up with setting up the system, which kind of SEM detectors are used. So there's the inlens detector or the HESE detector. As you can see here, there are different grades of contrast and of visualization offered by those certain detectors. So we went into evaluating the ultrastructure anatomy. So you can see here PE is identified for peripheral endothelium, TZ is transition zone, TM is trabecular meshwork. So here you can see several magnifications coming up, and so we were nicely able to further identify and characterize those specific cells or those anatomical structures. So the cells in the transition zone showed varying sizes and polygonal shapes, and those compared with the adjacent endothelial cells, which were regularly arranged, densely packed, and showed a hexagonal structure. So here you can see the trabecular meshwork, the transition zone, and next to this, on the lower left, the regularly shaped endothelial cells compared to the kind of fibrous or string-like shown transition zone structures. So to evaluate the cell density of the endothelial transition zone, we used an ImageJ system with manual counts, and here we saw that the density of the progenitor cells was a bit lower than the endothelial cell density in the periphery. The transition zone width was to over 70% more than 200 micrometers. So there was a similar analysis in the Yam paper where they identified clockwise variations of the width of the transition zone, and there also was a distribution correlating to the age. So the younger the patient, the donor cornea was, the higher the the width of the transition zone could be measured in our hands. So to conclude, using the RCM 2.0, we're able to examine a native specimen without fixation or and we're able to localize cells in different areas of the cornea. We observed areas where stem cells were present, also detectable using FISM. Stem cells were detected using immunohistochemistry in the transition zone, such as using markers as vimentin, nestin, LGR5, SOX2. So we have further developed the existing RCM2 with the aim of applying this to donor corneas for potential use in an eye bank setting, and further work, of course, is necessary to further identify TZ characteristics, for example, relative to the EC count, to donor cornea diseases, to donor diseases, or to the duration of the cultivation. So I want to acknowledge the colleagues who worked on this, and mainly Mrs. Stäke, Mr. Trosan, but also Mr. Walkling and Professor Starks and his team. And I want to acknowledge DGFG and the support. We had shown this work at ARVO in a talk, which was highly recognized, and we had multiple contributions to the ARVO meeting. So thank you very much for your attention, and if there are questions, please come up.
Hello everybody, I'll be talking about innovations in artificial intelligence in ophthalmology. These are my financial disclosures. None of them are relevant to the presentation. However, we own a startup called Nagranie Innovations, and I'll be briefly talking about one of the softwares for AMD prediction, which is owned by this company. In next few minutes, I'll be talking about introduction to artificial intelligence, current applications of AI in ophthalmology, what are the limitations, and what are the future directions. Let's start with brief introduction to artificial intelligence. As we all know, artificial intelligence is the ability of computer systems to perform tasks that are normally require human intelligence by leveraging algorithms, data, and computational power. Machine learning is one of the branches of artificial intelligence which is primarily used in developing systems or algorithms that are trained on large data sets to make decisions and acquire novel skills. Deep learning is a type of machine learning that employs multi-layer neural networks that mimic those of the human brains. In today's day, we are mainly using deep learning methods in medical imaging, which we'll be discussing more in detail. What is the difference between machine learning and deep learning? In machine learning, we require a labeled data set where we require an expert which helps to do feature extraction as well as classification before we train the algorithm. But in deep learning, we don't require an expert, but these algorithms can do the feature extraction as well as classification, sometimes in supervised as well as unsupervised manner. Let's talk about more popular deep learning models. What is CNN? CNN is a convolutional neural network which is useful for image processing. It uses series of filters. We are now using GAN network, which is generational adversarial networks, which is consisting of two neural networks. One is discriminator and the other one is generator. This networks are usually used for creating images, which has a significant importance in ophthalmology. We are also using NLP, which is also called natural language processing. It is useful for language comprehension as well as documentation, including large language models such as ChatGPT, which is again used commonly in day-to-day life. What is transfer learning? It is a model designed for one task that can be inserted as the starting point for a separate task. Again, transfer learning is used commonly in ophthalmology because we also use multimodal imaging data as well as data coming from multiple devices. If we really look into the AI application in healthcare, it has been there for many years. AI has been used in logistics such as inventory management as well as supply chain management, data management. AI has also been used in automation of billing, optimization of scheduling. We are intensively using AI in medical imaging in identifying pathology, quantifying disease progression. We also use AI in streamlining diagnosis process as well as patient monitoring. And nowadays we hear about wearable devices, which many of the patients, such as diabetic patients, are using. This all is based on AI, which has been there for many years now. Let's look into AI in ophthalmology. How is the workflow? We all use multimodal imaging such as OCT, fundus photograph, corneal topography. So these images need to be pre-processed before we really start using them into training models. This could be of three types. A supervised learning is where the expert is labeling the data and training the models. Unsupervised learning is when the expert is not required and the data is not labeled. The algorithm learns from the images itself. And there could be a reinforcement learning, which is a machine learning technique that trains software to make decisions to achieve the most optimal results. The reinforcement learning uses a trial and error learning process, which usually human use to achieve the goals. So these are three ways of training the models, but we sometimes use semi-supervised, where we train some data and also use that data for unsupervised learning as well. So let's talk about AI in ophthalmology in multiple diseases. Let's start with cataract. AI has been used in cataract detection as well as quantification of nuclear sclerosis, posterior subcapsular cataract, just by looking at slit lamp photograph as well as retroillumination images. This has also been tried using fundus images to screen for visually significant cataract with an AUC of 0.91 to 0.96. AI has also been used to improve the IOL calculation formulas. Very interestingly, AI has also been used for training for cataract surgery. Here you can see the multiple screenshots during the cataract procedure. So the deep learning algorithms are used to learn from these screenshots and detect the training ways for our trainees. What about corneal diseases? CorneaNet is one of the deep learning algorithm which has been used to learn from anterior segment OCT in patients with keratoconus and identifying keratoconus with an accuracy of 99.4%, and therefore AI could be used in diagnosing keratoconus as well as for screening for keratoconus. Deep learning systems have also been used for automated keratitis classification based on slit lamp as well as smartphone images, and these algorithms are used to differentiate between bacterial and corneal ulcer just by using the slit lamp photographs. AI has also been used in glaucoma screening, diagnosis, and prognosis. And as you can imagine, that glaucoma is based on imaging so much, so therefore the AI is really useful in identifying referable glaucomatous optic neuropathy as well as identifying glaucoma as well as predicting glaucoma progression based on visual fields as well. Let's talk about retinal diseases. As we all know that now FDA has approved two algorithms for diabetic retinopathy detection. One is the IDXDR and the other one is IART by iNuke. And these algorithms are based on deep learning network, which are useful to identify diabetic retinopathy with an accuracy of almost up to 90%. These are the heat maps used by integrated deep learning method, where the positive cases of referable DR are used based off these green colored areas, which are usually missed by the expert because of the poor fundus images. And by using these deep learning methods, we are able to refer diabetic retinopathy for further management. What about ROP screening? Deep learning methods are also used in identifying the ROP using fundus photograph as well as classifying, and are based on these the accurate referral can be done from the peripheral centers. AI is also used for AMD detection, where the multiple features were identified by using deep learning methods on fundus photographs such as large drusen, pigmentary abnormalities, and late AMD by using ARES dataset. These algorithms have also been used for fellow eye conversion by using OCT with an accuracy of 80%. What about identifying the AM wet macular degeneration? And there are deep learning methods which have been applied to predict visual acuity in response to anti-VEGF therapy in these patients by using these OCT scans. Eye images are not only used to detect ocular diseases, but also systemic diseases such as neurodegenerative diseases. These are some of the papers which have used AI methods as an indicator of the risk of cognitive decline, as well as differentiate Alzheimer's patients from retinal photographs with the presence and absence of amyloid on their fundus photograph. Ocular images are also used to predict cardiovascular diseases. These are some of the publications where they have used the retinal images to predict the risk of myocardial infarction, as well as identify the presence of coronary artery calcium deposit, which can be a predictive factor for future myocardial infarction. So what are the future directions in imaging particularly? So we are hoping to have advanced segmentation network, improve the sensitivity of these AI-based screening models, as well as applying continual learning methods, because now we are generating so much data and we would really like to learn from this data, which we are using right now for diagnosing as well as screening. Let's talk about large language models in ophthalmology. Large language models such as ChatGPT is very much part of our routine life, but this is also has also been involved in ophthalmology. So ChatGPT has achieved an accuracy of 55% in basic and clinical science question sets from academy, as well as now ChatGPT has been used to understand about vitreoretinal surgeries particularly, and compared with retina specialists with an appropriateness score of 85 to 92%. However, these responses are challenging to read for a layperson and require a college graduate level education. How are we looking into the large language models becoming a part of our practice, where people have tried these large language models in remote triaging, as well as linking these LLMs with mobile application in primary care settings? This will help us to streamline the appointment scheduling as well as automated form completion. And these LLMs can also be used for performing documentation such as discharge summaries and clinical notes, and particularly for ophthalmology education, where we can create simulating patients as well as summarizing text. So there has been a lot of concern about the privacy, particularly when we are talking about AI. So the possible solution for this privacy issues could be foundational models, where foundational models are pretty much a self-supervised learning to create labels from the input data. This means no one has instructed or trained the model with with labeled training data set. Therefore, it will help us to create data sets without any privacy issues. And what is federated learning, which is also called as collaborative learning? It is a decentralized approach to training machine learning models. It doesn't require an exchange of data from client devices to global servers. To global servers. That means that if we really combine the federated learning and foundation models, we will be able to advance the field and prevent and preserve the privacy and achieve a scalable AI systems. So what are the limitations? Current limitations are particularly in ophthalmology, that these data sets which are available are inclusive of only certain populations. So we do not have a diversity in our data sets, as well as we are concerned about the reliability. There is no explainable answers to many of these output, because many of these models were using black box approach, where we are not sure how the outputs were generated. However, there are a lot of ways we are able to explain the AI outputs, which we will learn with time. And there is definitely an issue of image quality, such as artifact, which also can be influencing the output. And as we discussed earlier, that there is definitely concern about privacy as well as data protection, and how do we deal with the informed consent from these patients where we are using the data. So with this, I would conclude saying that AI is here. AI is here very much here, and we are yet to learn to adopt AI, as well as there are many questions which we need to answer in terms of safety, explainability, trustworthy, as well as regulation. With this, I would like to acknowledge my lab and the funding agencies which have supported some of our work. This is our team at Choroidal Analysis Research Team, which is focused on AI-based solutions. Thank you so much for your attention.
Now we can start the discussion. It's open for placing questions at the chat for everybody. I would like to welcome again, Thomas and Jay. So good to have you with us. Thank you for both contributing to our meeting and being with us this time. Unfortunately, Christine could not, she was present for a moment, just watching Thomas' presentation, but because of her flight somewhere, she must left, unfortunately. We cannot discuss a really genetic paper. But I have a question, Thomas, for you. Because today we speak about innovations. Different subfields of ophthalmology. So what are the, let's say, unmet needs in the cornea diagnostics for the future? What do you think?
Yeah, so our concept, so basically when it comes to corneal transplantation, the same criterion has been in place since the 1970s. And this is central endothelial cell density. So there has been rather innovation on the way to analyze the cells. If in former days it was a Polaroid photo, you had a cardboard, you had a certain kind of square, you counted the cells manually, you had a multiplication factor, and then you could calculate your cells per square millimeter. Then you had a software-based thing where you could click the cells. Now you have an AI that suggests or automatically counts the cells. But basically, we talk about the entire back surface of the cornea, and the criterion we use is a part of different kind of culture or donor-related things. But the real tissue parameter is a tiny piece of square millimeter in the center of the cornea. And people who work in eye banking know that it is well possible to do several photos or to choose a very favorable photo to get your cell count over 2000 cells per square millimeter, just to be able to give it away to the operating room. Because if you're under 2000, you have to trash it. Yeah. So there had been approaches to do a kind of entire back surface scan and to count multiple square millimeters and to do a ratio, but industry did not, unfortunately, pick up on this. So we still stick to the same parameter. So our idea was to look at the progenitor cells on the edge of the cornea. And this is able to analyze to date by fixation, by electron microscopy or confocal microscopy. But with that rostral cornea module, or kind of different approach to the rostral cornea module, we can take it out from the cultivation room. We can put it on. We could do a sterile environment and then analyze it, take a photo, put it back again, have a criterion on the progenitor cells, and eventually have corneas that are below the 2000 cells per square millimeter criterion, but they have a high density of progenitor cells and anyway could go into the operating room. Because if you're a clinician or a surgeon, it doesn't really matter, and everybody knows if you have a 1900 cornea or a 2100 cornea. In the truth is that sometimes it's only 3 or 4 cells. You click, and then you're like 80 cells over or below, and this is in a way biased, and we try to get over this.
Thank you for this comments. And well, by the way, I have a question. What is the percentage of the cornea transplants in your practice after the cataract surgery, after the complications of the cataract surgery? Would you assume, how big is it?
You mean how many corneas degrade and need a cornea transplant?
After, yeah.
Yeah,
surgery.
yeah,
Post-cataract.
Post-cataract. So
roughly saying, I mean, well,
yeah, it has gone down very much, and the reason is the innovation in phaco technology, like pulsed phaco, pulsed ultrasound, or increase of suction and pulsed ultrasound. So it used to be much more, like 20 years ago. And as Fuchs is not a big problem in Japan, apparently, bolus keratopathy after cataract was the main reason for cornea transplantation in Japan. But even there, it's now going down. So luckily, so to say, the iatrogenic impact on the endothelium and corneal decompensation goes down because the industry is getting out better phaco machines.
You mean, yeah, I agree, but you mean 10% or even lower than 10% or?
So we see less, what we see, but this is because we're a university hospital. We see decompensated corneas, and this could be in both eyes because of cataract in Fuchs endothelial dystrophy. Yeah.
Yeah.
So if you have a kind of brunescent nucleus or lens and you do a phaco and you have underlying disease just as like Fuchs endothelial dystrophy, then of course you have a much higher probability to get decompensation, which then requires corneal transplant.
Yeah. Thank you. Jay, well, I have a question for you because, well, obviously we have so many algorithms available, but so few applications. What is the problem? Why do we have so few applications? What do we need more to?
Great question. And I think this is one of the biggest challenge for all of us who are working on this side of the table. So I would say that there are multiple algorithms which are being reported, published, patented. But one of the biggest challenge we as a clinician and as a researcher understand that many of these algorithms are not trained on real life data. So what has happened is that these algorithms are trained on a limited set of data in the best quality images, but as soon as you go into the real life data, they fail miserably. So this is one of the efforts which we are taking in our research lab, where we are exposing these algorithms and training them with the real life data. So I think this will only get better, and this is where a lot of newer deep learning methods are useful, foundation model, diffusion models, where we can work much faster and try to get more accurate data. So I think we are still not there yet, but hopefully very soon with more and more real life data, we will improve.
I agree. I remember you mentioned about your own startup. I mean, Netramind Innovation. So could you tell a bit more what you are developing? What is your work on?
So thank you so much. Yeah, though this is like a work of almost 10 years. So as you probably are aware that I was very much focused on the choroid, and what we decided that, we should really take this into the commercial level because still not many choroidal algorithms are available. So the purpose of the company is to provide, right now we are not FDA approved. We are targeting that in next 1.5 years. But our goal is to actually make these algorithms available primarily for the research at a very cheap cost, just because we know that these algorithms are being more and more commonly used. Along with the choroidal work, what we have done, we also have a product for retinal layer segmentation, because many of the OCD devices are not providing retinal layer segmentation. And one of the unique parts of this product, which has come originally from me, from a clinician who suffers between the multiple big device companies. And our algorithms are device agnostic. That means we really don't care from where the images are coming. Our algorithms are already able to do great segmentation, analysis for Topcon's eyes, as well as Heidelberg. We are not yet expanded into other OCT systems, but we are there. Along with that, we are hoping to come up with, we have just submitted a grant through the company for AMD predictive modeling. So the idea is to really take the OCT to really low cost analysis as well as predictive modeling.
Thank you.
You will hear more soon in coming.
I'm sure. Yeah, you are very productive. Thank you, guys. We need to finish discussion now because it's time, and finally also to finish the conference. So I would like to thank you so much for your contribution and for your discussion. Thank you.
Thank you so much. Thanks for the opportunity. Pleasure seeing you guys. Thank you so much. Bye-bye.
At the moment, this is the time to finish, to close the conference. I would like again to thank all of the contributors, sponsors of the conference, and all attendees to spend the whole day of education. I'm sure that we all learned a lot from our other colleagues, from experts that described different innovations in ophthalmology. Thank you so much.